Good afternoon. Welcome everyone to the Senate Committee on Health and Human Services for the 83rd Legislative Session. Madam Secretary, please proceed to call the roll.
Senator Lang, Senator Stone, Senator Taylor, Senator Titus, Chair Doniate.
And I'm here. Please mark Senator Lang absent excused and Senator Taylor present when she arrives. Good afternoon, everyone, and thank you so much for joining us for today's meeting. Today we have a bill hearing on Senate Bill 182. And so I'm going to go ahead and do that. But before we begin, I do have a few housekeeping items. Please note that there are a few things for folks that want to participate for today. So first things first, if you wish to testify, we ask for folks to please sign in at the table by the door and provide a business card to the committee secretary. If you do not wish to testify, you may want to sign in so that there's a record of who is interested in a particular bill, or in the event the committee needs to contact you later. When testifying today, please turn the microphones on to speak and off to listen. And we ask for listeners and viewers in Las Vegas online and are recording this meeting, so it will be available on the legislature's website. For those who would like to participate today, it looks like it's a popular conversation, so we ask that comments be kept to 2 minutes. We respectfully ask that they're kept to 2 minutes so that everyone interested in speaking can be accommodated and we can get through the agenda in a timely fashion. I want to reiterate that we have a lot of folks that want to participate today, and so to just be mindful, right? The longer we speak, the less time that other folks can have the participation of this process. And so it's okay to say ditto as we're going through this, at least through the several rounds of this. And as I mentioned, speakers are urged to avoid repetition of comments made by previous speakers. And finally, we ask for folks to please turn off their electronic devices or put them on silent mode throughout the meeting. I'm going to go ahead and open the hearing now at this time on Senate Bill 182, so I'll invite Senator Nguyen to please come forward along with her presenters. This bill revises provisions relating to the staffing of healthcare facilities. Before our presenters begin, I just want to go over the logistics of how today's bill hearing will work. So we are going to start with the presentation from Senator Nguyen and her co-presenter. At that time, once they are concluded, the committee members will go ahead and ask questions to our bill sponsor regarding the bill contents. And then from that moment on, I will go ahead and open testimony for support of the bill. We will do 30 minutes in support of the bill, 30 minutes in opposition to the bill, and 30 minutes in neutral. After support testimony concludes, we will go on to opposition. At that point in time, we will have the Hospital Association come up and present from their section of the bill, and then we will begin the opposition testimony, the 30 minutes from that moment on, and then we'll follow on with neutral testimony. So this is a process that we have elaborated just for everyone to have transparency's sake, and so I just wanted to make sure that folks know what section of where they can participate. So at this time, if our bill presenter can please begin.
Thank you, and good afternoon to everyone. It is International Women's Day, what we're recognizing here in the legislature today. Hence the reason you see so many people either wearing white, purple, or I believe green is also an acceptable color to recognize the event. And I can't think of a better day to present a bill today, Senate Bill 182, that predominantly affects women and the workplace. So I'm really proud to be able to present this bill. I'm really proud to be able to stand here today on International Women's Day and present such an important bill. What high level Senate Bill 182 hopes to and seeks to improve is improved patient outcomes, reduce nurse burnout and turnover, increased patient satisfaction, cost savings ultimately in the long runs, standardized care across facilities, and preparedness for public health crises. I'm also very excited to be sitting here today next to who I will later turn over this whole entire presentation to, is someone that many people in this building know, and if they don't, when we talk about the people that are leading our state and our young people that are doing great things, the person sitting next to me definitely fits that bill. She comes from a family, she's Nevada, born and raised, grew up and raised in Las Vegas. She comes from an entire family of healthcare workers, and in fact, I think she is the only one that is not, although she is a former CNA, so she does have that experience. I got to know her in 2023 when she served as a legislative attaché in the same year that she graduated from UNLV. I'm proud to know her. She has flown in from the day. She is currently getting her master's in public policy from Harvard, and it is every intention when she graduates this spring to take the knowledge that she's learned not only from our Nevada institutions, the Nevada legislative experience that she has, and now her new master's degree from Harvard, to come back here to Las Vegas and come back to the state of Nevada to continue to do that work. And so at this time, I am going to turn this presentation over to Karen Yap, and I believe we also have Renee Ruiz and Cody Hoskins later on, but for our initial presentation, it will be on Karen Yap, Jody Dominic, and Liz Bolthouse. So I will go ahead and step back and turn this over to them to begin the presentation.
Thank you, Senator. Hi, everyone. For the record, my name is Karen Yap. Like Senator mentioned, I'm a proud Nevadan. I'm a former Filipino nursing assistant and former legislative staffer, and I was raised in Las Vegas. I was not born, but in K through 12, and then also a graduate of UNLV. So Chair Donyate and members of the committee, I'm honored to have researched and now present Senate Bill 182. Today, Senate Bill 182 implements safe staffing and working conditions to improve the retention and satisfaction of Nevada nurses and nursing assistants, which are also referred to as CNAs, as well as increase patient health outcomes and mortality, lower cost of care, and prioritize patient safety. So what does this bill exactly do? From a high level, there are three main points. The first being safe staffing ratios for nurses and CNAs. So a staffing ratio are these standards for adequate staffing between the number of nurses and the number of patients they care for. So for example, in medical surge units, you'll have 1 nurse to 4 patients, and this will vary based on the unit. Secondly, it creates focused staffing committees, so to now create 3 separate committees, nurse, service, and technical staffing committees, and all 3 will collaborate to create a staffing plan, which I'll go over later. And third, this bill establishes reporting and enforcement mechanisms to ensure hospitals are compliant with agreed to staffing plans. So I'll go section by section. So if you have the bill in front of you, section 1, 2, 3, and 4 go over different definitions. So it defines a direct care nurse, service staff, which means you interact with patients, but you don't provide medical care, and then defines technical staff as servicing medical equipment and machinery. If you go into section 5 and 6, this establishes the technical staffing committee as well as the service staffing committee. So all of this legislation is applicable for hospitals located in a county whose population is 100,000 or more and licensed to have more than 70 beds. So at this rate, this only applies to Washoe and Clark County. So currently, Nevada has these staffing committees in hospitals consisting of one big staffing committee created primarily made up of nurses and other hospital staff who develop and review staffing plans to ensure safe patient care. Now, we're hoping for the establishment of 3 staffing committees, like previously mentioned, nurse, technical, and service, to create more focused care for both patients and technical service providers. Then, if you go down into section 7, it establishes these reporting requirements annually. Section 8 is really this big bulk of the bill that touches on the safe staffing ratios that we discussed before. So these ratios are for maximum number of patients that may be assigned to a direct care nurse. These minimum mandated nurse to patient and CNA to patient staffing ratios are in order to protect our patients' right to nursing care using guidelines from national standards and mirroring other forms of state legislation. These numbers are based on the care needed of the patient and the unit themselves. I won't go through all of them because there's a friendly amendment that will be going over some specific changes, but one thing I did want to highlight is that hospitals with certified nursing assistants will have the ratios of 1 to 7 from 6 a.m. to 8 p.m. and 1 to 11 from 8:01 p.m. to 5:59 a.m. The rest of this section 8 goes over 1-to-1, different sorts of units, but again, I'll leave that for the friendly amendment. Section 9 goes over the maintenance of accurate daily records, so the number of patients admitted, released, and present, and then some others as well. Section 10 touches on the labor commissioner shall collaborate with the division to ensure compliance, so this includes inspection of a healthcare facility, investigating any alleged violations of this bill. Section 11, 12, and 13, there's some semantic language just correcting to make sure everything is consistent. And then Section 14 is also being removed with a friendly amendment, and so we'll go over more of that later if you have any further questions. And then Section 15 is reporting to the division of the Labor Commissioner about any information about potential violations. And then if you go down to Section 18, it establishes this collaboration between this new nurse staffing committee and these newly established technical and service staffing committee. As you go into Section 19, it goes further into the documented staffing plan, making sure that healthcare facilities that are hospitals conform to these maximum ratios, and then additional compensation for licensed nurses who take on extra preceptors, so they're teaching and guiding new nurses, are assigned to flow, and this is consistent with some previous standards as well. The last thing I'll go over is Section 22, which is accessible and confidential system to which hospital staff may report the failure of a healthcare facility. So this ensures compliance with timely investigation and resolving a report. So ultimately, research has shown that each additional patient assigned to a registered nurse beyond the optimum ratio significantly increases the risk of preventable death, longer stays, readmissions, and unfavorable patient satisfaction. At the core, SB 182 addresses patients getting the care they deserve and hospital staff receiving good working conditions. I'll now pass it off to registered nurses Jody Dominic and Liz Bullhouse to discuss current hospital working conditions. Thank you.
Thank you, committee chair and members. My name is Elizabeth Bullhouse. I am a nurse of 27 years, and 25 of those years have been in this great state of Nevada. I am a member of SCIU Local 1107. I'm employed at a public hospital in Las Vegas, and at that hospital, I am the elected SCIU Chief Steward of Nursing, and I represent around 1,800 nurses and certified nursing assistants.
Hello, Jody Dominic for the record. Thank you, Chair and Committee. My name is Jody Dominic. I am a born and raised Las Vegan. I am also an RN of 19 years at a private hospital in Las Vegas, as well as an SCIU 1107 member. Right now, when a nurse takes care of a patient, we are the eyes and ears at the bedside. We are the hand that they hold. The time we spend with them, the assessments we make, the care we provide is often the difference between life and death, or a good experience, or a traumatic one. The time that we spend with each patient affects their care. It affects their outcome. It also affects us. The ability to practice and give your highest standard is what we take home at the end of the night. When we have additional patients, there is something that we aren't able to do. Whether that is an assessment, a bed change, a bath, whether that is holding a hand or educating on a new medication. When there are more patients added, something has to give. And oftentimes that is the human touch at the bedside. There have been times when I have had to walk away from a crying mom in a hallway while her child was undergoing a procedure in order to provide care for other patients. Something always has to give when we keep adding patients. Nurses are leaving the bedside due to this moral injury of not being able to give your best. We are trained to provide the highest level of care as well as emotional care to our patients. And the more patients we have, the more that gets left when we can't provide that.
Nurses are leaving the bedside or leaving nursing altogether due to burnout. 33% of new nurses leave their job within the first year, and up to 56% leave the second year. We believe we have the statistics to validate that this bill is necessary. At my current hospital, new grads will sign an education contract saying they'll commit 3 years to the hospital in exchange for their training. And if they leave early, they'll have to pay back that training. And as the Chief Steward of Nursing, I've represented nurses that are willing to pay back the cost of their training program as they no longer want to stay in the field of nursing.
There have been times where on units a nurse has 10 patients. When you have a 12-hour shift, the first 30 minutes you're getting report. You're finding out those patients' names for the first time. That leaves 11 hours and 30 minutes that you have to provide care for 10 patients. That means there's less than 6 minutes an hour per patient. When you listen to a heartbeat, you need to listen for a whole minute to check the rhythm. When you listen to the lungs, you need to listen in all the fields. There's 2 of your minutes. When we add more patients, we take away the time that we are providing care. How are you able to provide safe, competent care at less than 6 minutes an hour? Add your hand washing, add a phone call to pharmacy. How much time are you able to care for your patient? That time disappears, and that's not counting a lunch or some graham crackers in a nutrition room. That is if you gave every minute to your patients. This is why we need ratios so we can provide the highest level care to our patients.
We believe hospitals are putting lives in jeopardy. NRS 449 gave us safe staffing councils and the assignment despite objection form. We call it an ADO form. An ADO form is filled out when a nurse or nurses arrive to the unit and they believe that their assignment is beyond their capacity, but they are willing to do it under objection. There is usually a call to management to try to mitigate the concern. In the past 4 years, in just 2 hospitals in Nevada, there have been over 6,000 ADO forms submitted. Some hospitals will try to process the ADO forms and do a trend report, and some hospitals will treat the ADO forms like junk mail. Each ADO form represents a patient or a nurse being put at risk, and a nurse does not fill out an ADO form lightly. It takes up much of one's time, and you truly do it when you feel there's a significant issue that needs attention.
Nurses are held to standards set forth by the Nevada State Board of Nursing. We are also held to our professional standards. There often comes time when there are additional patients that you're not able to meet those standards. And often that's come down to nurses having to choose to protect their license or to keep their job, because sometimes the jobs don't let you safely practice nursing. And ultimately nurses have left because they feel that their license is in jeopardy, because they cannot meet the safe standards that they are held to. That ends up meaning less nurses at the bedside.
If I may share a shameful secret, when I finish my clinical shifts at the end of my week, I come home to my family and I tell them, I made it another week. I say that because sometimes you feel like you just escaped the fire and you're not looking forward to going back in. I represent several nurses at my facility, and I get text messages of nurses that have tried their best for 12 hours, and at the end of the day, they're in the car crying because they realize they did not give the care that they need to give or that they came into this profession to give. Nursing is not just a career, it's a calling, and if we cannot give the time our patients need, it has a significant impact on our well-being.
I had the same sitting in the car at the end of the shift, feeling like I didn't do enough, even when every minute was given to my patients, even when I went without a lunch, even when I didn't go to the bathroom until the end of the shift, and I still feel like I failed my patients. I thought, again, that was a personal failure. Come to find out, almost every nurse has that story when they have too many patients. This isn't just about the nurses, though. Our lack of time affects the patients more than that is the highest thing. When there is more patients, nurses can't do everything. The things that may get left behind may be a turn that prevents a bed sore, maybe a bath that prevents an infection. When nurses are able to do those things, we prevent complications. Those complications often becomes the hospital's financial responsibility. When we can provide correct care to our standard, we can prevent complications that save money for both our patients and the hospitals. A 2021 New York study found that ratios would have saved hospitals $720 million over 2 years. They also reduce readmissions, and readmissions within 30 days are usually not reimbursed. The time that we can spend educating and ensuring a proper handoff of care can decrease those readmissions. We've seen nurses leave the bedside. I know many personally. The hardest part of today was deciding which stories to share. I know nurses that have started at the bedside at a hospital and not been able to do it. They didn't feel safe. They didn't feel that the patients were safe. And they couldn't live with making a mistake that would hurt them when they have too much to do. We know that there are nurses that leave to go to states where there are better nurse-to-patient ratios, where they can safely practice nursing to the highest level. There are also nurses that would come back to the bedside if it was safe to do so. I have shared this bill, and I have several people that have said, I would be back in a heartbeat if I could take care of patients like that. And that is what we hope to do with this bill. There are times right now, a coworker of mine was on shift, and her mother was hospitalized at another hospital, and she was talking to her on lunch, and she put her call light on to use the bathroom, and her mom was updating her. 45 minutes later, nobody had come to help her to the bathroom. Her mom was a fall risk, but she didn't want to soil the bed, so she was trying to convince her mom not to fall out of bed and to just soil the bed. As another nurse whose job it is to take care of people, to see your own mother suffering from lack of care, and that's unfortunately what we're faced with. Not only is it the dignity of our patients, it's their actual lives. Data in 2021 out of New York showed that staffing ratios would have saved 4,300 lives over 2 years. A Pennsylvania study found that each patient added to a nurse's workload beyond these ratios increases the patient's odds of a 30-day mortality by 16%. That means 1 in 6 patients may die that didn't have to.
We believe we have the statistics to support this bill. After passing staffing ratios, states saw more RNs, more applicants, and more actively licensed RNs grew up to 3 times faster than before. SB 182 will save money by reducing negative patient outcomes and readmissions. SB 182 will save staffing by retaining and bringing nurses back to the bedside. SB 182 will save lives by ensuring nurses can provide the proper care to patients.
Thank you both for sharing, and thank you all for listening. Lastly, I just want to highlight all the nurses that are not with us today, whether they're working the day shift, have left the state completely, or have passed under dangerous working conditions. For further perspectives on these unsafe work conditions, for those who couldn't be here today, there are now over 1,060 opinions on Nellis, and encourage you all to read through. Now, we are going to hand it off to Renee from National Nurses United to review the friendly amendment.
Good afternoon. My name is Renee Ruiz, R-E-N-E-E-R-U-I-Z. I represent National Nurses United, National Nurses Organizing Committee of Nevada. I represent the interest of over 3,000 nurses in the state of Nevada. And for the record, I first would like to thank Senator Nguyen for sponsoring SB 182. And I would like to also thank SEIU and the Senator for working collaboratively with us to talking through how to best benefit the patients in Nevada, the public in Nevada, but also the nurses and healthcare workers in Nevada. So our friendly amendment that we proposed is First and foremost, it defines a registered nurse for the state of Nevada. And further, it talks about staffing ratios. Staffing ratios set at a minimum standard based on research, evidence, and best practice. The friendly amendment addresses proposed ratios that are based on the most current evidence. A lot has been learned since 2005 when the first statewide staffing ratios went into effect in another state in the country. Patients who are in ICU in 2025 would not have been alive if they were in ICU in 2005. With advancements in technology and science, this means bedside care is more intense. Ratios will provide a safe minimum level of staffing. Hospitals will still have flexibility in staffing, but cannot go below the levels that the research demonstrates are safe. The amendment also includes that it would allow the labor commissioner to receive the complaints when the ratios are not met. And we have decades of research to back up why safe staffing ratios are important. Just a few examples. The nurses, the SAU nurses did speak on some of these. Each additional patient per nurse in a hospital med-surg unit increases odds of death. Hospital nurse staffing ratios mandated in California are associated with lower mortality rate and nurse outcomes predictive of better nurse retention in California and in other states where they occur. Nevada has more RNs working today than it has had at any time in the past. Nevada also has a massive surplus of licensed RNs who are not working at the bedside because of unsafe staffing and their inability to provide all the care their patients need. Safe staffing ratios will bring nurses back to the bedside. The number of total nursing assisted personnel, which means like the CNAs and other folks that work with patients at the bedside, increased by 64% in California hospitals since 2005, after ratios were implemented. That is a rate of 55% higher than the rate of increase in hospital nursing assisted personnel care nationally. And that was in the American Hospital Association's annual survey from 2005 to 2010. Evidence and experience demonstrate that safe staffing is a cost-effective way to improve patient care and can lead to savings for our hospitals and our healthcare system. Unsafe staffing hurts the bottom line by increasing rates of costly hospital-acquired infections, patient falls, 30-day readmissions, medical malpractice, nurse burnout, and staff turnover when compared to healthcare facilities that meet safe staffing levels. In California, hospital income rose dramatically after ratios were implemented, from $12.5 billion from 1994 to 2003 to more than $20.6 billion from 2004 to 2010. Again, I'm going to repeat this because this comes up a lot. Not one California hospital closed due to the implementation of ratios. Over the past couple of years, while NNU, NNOC, SAU, we've taken the lead on staffing ratio and working on legislation across the country, the American Nurses Association has nationally made it part of their agenda to work on safe staffing ratios. Since 2009 in Nevada, nurses have done their part in the mandated staffing committee in each facility. We played the game the employers and the hospital association said would fix the staffing problem in Nevada. Every quarter, the nurses The nurses go to the committee meetings and are left with thousands of unanswered assignment despite objection forms, which the nurses further explained, the ADO forms. Thousands of them have gone unanswered by management in the hospitals that are directly about unsafe issues that occur daily in the facilities. These forms do not just go from the hand to the nurse to the staffing committee. They actually go up the chain through management. So each manager sees these. The ADO forms for, especially, like we know for our NNU represented facilities, and I believe in the SEIU facilities as well, are based on the Nevada Nurses Practice Act. And that Nursing Practice Act, which governs everybody who has a nursing license in the state, at the end all be all is to create no harm. And that includes every nurse who holds the title of nursing manager or chief nursing officer or above. And finally, we have participated in the staffing committees. We have been here since 2009 when the staffing committees originated. We have watched every legislative session where they have been tweaked. The staffing issue is still the same. Nurses are still leaving the bedside. Our patients are not getting care in the way that they deserve. And the moral injury to healthcare workers is long lasting, and we will be paying for those effects for a long time to come. Thank you.
Thank you for allowing for some indulgence with this presentation and some of these stories. And at this time, we are ready to take any questions that you might have.
Thank you so much for the presentation. I know there was different presenters and so forth. Before we begin the questions, can you just walk us through the amendment, just really quickly, top line of what were the changes?
Okay, the amendment addressed changing licensed nurse to registered nurse to more clarify. Most of the amendment is actually clarity of language in the original bill. The significant change is in section 8, where the numerics of the ratios changed and the units were more defined. So that's basically where the changes were made. There was clarity in the ED language, adding the triage nurse that must be present at all times, as opposed to be putting it in the mix for care. The addition to the piece on the labor commissioner, where the language originally addressed the labor commissioner would be able to investigate, but there was no mechanism to actually receive the complaints. So it's basically just tweaks of the current language and the addition of just more more definition around the ratios.
Rochelle Wynn for the record as well. We look at section 4 and you can see that we eliminated it. The people that were willing to come to the table and talk about amendments that needed to take place to make this a better, more to bring clarity to the bill, section 14. I'm sorry, section 14. Section 14. You can see that we have eliminated that complete section because after talking to some community partners and talking to people that work in this field, we realized that some of these requirements were redundant as they were already being reported in other things. And so this is an example of where we were able to remove certain sections after talking to stakeholders in this area. Same thing with the labor commissioner's recommendations. In order to carry out the intent of our bill, we were able to incorporate some of those recommended changes to make sure that they were able to actually receive the complaints and we weren't just setting up a system that did not address that.
Great, thank you so much. Plenty of questions. Let's start with Senator Stone first.
Thank you, Mr. Chair and Senator Nguyen and the presenters. I appreciate the presentation, and to all the nurses that are in the audience, your Herculean efforts have been noticed by me for many, many years. I was a county supervisor, you call them county commissioners, in California, in a county that almost approximates the entire population of Nevada, and we had a county hospital, and I worked very closely with SEIU, and I see a number of you in the audience, to increase your wages so that we could fulfill a gap in nursing that we had in our county hospital. So I want to just say how much I appreciate that you're all here. And I do have some concerns about the nursing ratios bill here today. And so I'll begin with a few questions, if that's okay. So according to the U.S. Department of Health and Human Services, Nevada faces a deficit of 2,190 nurses. Nevada ranks 46th in the nation for nurses per capita. Nevada needs 3,162 additional RNs to reach the national average. So won't the implementation of nursing ratios increase the demand for nurses in Nevada and exacerbate the shortage that we have statewide? That's the first question.
Thank you, Senator Stone. I can begin. Oh yes, my name is Karen Yap, for the record. So this bill is focused on nursing retention, specifically, although nursing shortage is kind of the language that is used often, I think an alternative language that we like to use are shortage of hospitals with safe working conditions. And so this focus on nurse recruitment has been something that's been a priority for Nevada in previous years. So, for example, last session in the 2023 legislative session, SB 375 was passed to expand the different nurse cohorts of the 7 different nursing programs, et cetera. And there have been continuous efforts to increase nursing recruitment. But this particular bill focuses on nursing retention. And so because there are so many nurses that leave after 1, 2, 3 years, part of the belief in the mechanism here is if we increase the amount of nurse retention after those 1 to 2 years, that nursing shortage won't continue to be exacerbated. If you have anything to add.
And Rochelle Wynn, for the record, I think that's a great question. It's one that I asked when I was contemplating bringing this bill. And when you look at other states, we're not alone in a nursing shortage. When you look at statistics, in fact, we rank actually not as low as some of these other states that have nursing ratios. And I think one of the most telling statistics that we heard during the initial presentation was that in our first year, we are spending all this time and all these resources to increase nursing apprenticeship programs, increasing the number of spots at our nursing programs in schools across our state. We are even creating schools and having private schools that are coming in, creating more nursing programs. And what good is all that investment going to be in the education of nurses when we have 33% of them that are willing to leave after the first year and 54% of them that are willing to leave after their second year? So that investment in this workforce is for nothing when we are not encouraging and we don't have safe environments for these nurses to go and learn and work in. I always think that this is actually a savings for the hospitals, and they may disagree with me, but the amount of money, when you come out of nursing school, just like you would come out of pharmacy school or medical school, the investment that these hospitals and these institutions are making when they decide to hire on these new nurses is they can put a dollar amount on that too. I think on average they spend around $40,000 investing in these nurses, not just in their salaries, but in the training and the retention. And if they are not able to retain these nurses because the nurses don't feel safe providing the care that they were trained for, that's another cost loss in that. So our argument is, and it always has been and it will continue to be, is that this is less about a nursing shortage and more about nursing burnout, and we are losing nurses by the thousands because of these conditions.
Thank you for those answers, and I've got a couple more, Mr. Chair, if that's okay. So I'd like you to comment on the potential drawbacks of imposing nursing ratios, and I'll mention a few items. Inflexibility of staffing, ratios that do not account for how sick patients are or the experience levels of nurses that are taking care of these critically ill patients, let's say in intensive care. Some patients might require more care like intensive care, and making numerical ratios less effective. increased costs for hospital leading to high costs for patients and insurance providers. And then also, as you know, we have UMC, which is mostly union nurses that are a part of the PERS system. I didn't see a fiscal note. Is there a fiscal note on the bill with respect to the overtime that's going to get paid, in making sure that we have enough nurses to meet these ratios?
Rochelle Wynn, for the record, I am going to phone a friend. I think that people that work in this field are probably best equipped to answer some of these answers and the implications. As far as the financial and fiscal implications, the bill has been open from the beginning. I pre-filed it, so it is one of those bills where people can put fiscal notes on it, the county, the state, and so I anticipate they will. And if there are, then you will see this again, Senator Stone,
Yes.
in our money committees. But I will turn this over to Jody here.
Jody Dominic for the record. Thank you, Senator Wynn. Right now, this bill establishes minimum staffing. They can always staff to the needs of the patient. That is our goal, is that we establish a minimum. Currently, hospitals do adjust staffing based on hospital acuity. This just establishes that minimum level. If a patient requires higher staffing, that can absolutely happen. And that is the goal, is that they can always meet the needs of the patient, but that there is a minimum level that we can always meet. Hospitals have flexibility in their staffing now. Nurses do float amongst units to meet the needs of the patients when able, but this is the minimum standard that we're establishing. Thank you.
Thank you. And I'll have just one last set of questions, and that is, what if hospitals cannot meet the staffing requirements? Is it going to result in big fines, potential litigation? Are hospitals going to have to turn patients away? Are they going to have to reduce the number of available beds? Are they going to have to close units in the hospital, limiting access to health care? It just is not a one-size-fits-all. Rehab hospitals, as an example, probably have a different staffing model than acute care hospitals. So if you could please answer those questions.
Thank you, Senator. Dakota Hoskins, Political Director for SEIU Local 1107, through the chair to you. So I hear your concerns. That's something we considered as we were drafting kind of what an enforcement mechanism could look like, right? If you're going to have these ratios. So currently in NRS, there's already these outlined. We actually did not add any additional enforcement mechanisms that are not already in NRS, right? So based on the current staffing plans that they were supposed to be following from our staffing committees, these disciplinary measures can already be applied. All we did in terms of the enforcement mechanism was allow the labor commissioner to investigate them and to take those reports. But there's no difference than the same punishments and disciplines that they can already receive. So that ranges, like you said, to small fines. It can range to working with management to figure out how to address those issues. I don't think anybody here's intention, though, is to close down hospitals, and we've also not seen that historically as far as we can tell, in any state, so especially in California, where there's been any that have closed due to staffing ratios.
Thank you. What about hospitals cutting back on numbers of beds or closing down units because they don't have the appropriate number of nurses to staff those units?
Jody Dominic for the record. Thank you for the question. Right now, the same patients are being taken care of. We are attempting to provide a higher level of care for those patients to meet the standards. The same patients are receiving care right now. We just want to make a minimum standard that would attract nurses to be able to operate safely at the bedside. Those same patients are receiving care. There shouldn't need to be an adjustment in beds if we are attracting the nurses and we are having nurses stay in the state of Nevada. I know nursing students that see the workload and the way that care is delivered compared to how they are taught to deliver care, and they are completely disillusioned with being a nurse in the state of Nevada. The goal is to raise the standard in the state of Nevada and keep providing care for the people in the state of Nevada at the highest level. Thank you.
Dakota Hoskins, Political Director for SEIU Local 1107, through the chair to you. Senator, on top of that, currently based on reports we've seen, just Sunrise Hospital alone had net patient revenue of over $800 million just in 2024. We have hospitals across the valley and across Nevada opening new wings and expansions constantly, yet we're being told that there's not enough staffing. And so I think the question would be, how do we justify opening up those if we're not able to provide the healthcare coverage that patients deserve, right? So we think that it's not an or, I think it's an and. So thank you.
Thank you very much for your answers, and again, I want to express my ultimate respect for all the nurses that are here today. Thank you for your service.
Thank you, Senator Stone. Senator Titus.
Thank you, Mr. Chair, and thank you all for being here. First and foremost, I want to tell you, you're way too serious out there. I've been in hundreds of committee rooms, and I feel like the weight of the world is in this committee room. So please, I appreciate all of you being here because I think you're all here for the same reasons. We increase access to healthcare, and that's why I ran for office to begin with, and I think that's what your intent is, and the argument for being here is that you want to make sure that there's nurses to give care to patients, and you wouldn't have entered the nursing field if you didn't feel that way. So first and foremost, lighten up a little bit. This is the early part of this hearing and lots of questions, but again, no one's the enemy. We're all here for Nevadans, and so let's keep that in mind. The good news is it's snowing out there, and we needed more snow. So think about that, and just don't have any injuries slipping on the snow. I have a bunch of questions, and I want to start off by saying I started my career in healthcare while I worked in a vet's office, and nobody wants to do that and get bit all the time. So then I became a nurse's aide. So I started as a nurse's aide at the VA hospital in Reno. And I know about not having nurses. I know about walking in a room, literally the first person dead person, I wasn't sure they were dead. I was young, and I remember it like it was yesterday. I'm 71 now. And that first person that I walked into by myself into a room is with me today. So I get it. I've been there trying to change a patient, and even to this day in the long-term care unit, I've tried to roll people over by myself. I change beds in the ER by myself. I do whatever needs to happen. There are some significant concerns I have regarding this bill, but I understand where you're coming from in this bill. One of the things I appreciate about it is that you did say 100,000 populations. As a rural physician working in a rural hospital, one of my questions and concerns about it is, I get that you try to limit it to that size, but we truly don't have enough nurses. We don't have enough of any single professional licensure in the state, and we're not the only state that way. So there's not enough RNs, there's not enough nurses assistants, there's not enough doctors, PAs, nurse practitioners, all along the line. One of the things that happens in the rurals is we have our traveling nurses to staff. Really worried that when you have a bill like this that now mandates increasing staffing ratios, hospitals in the urban setting can afford to pay more than we can in the rural area. So address for me, I know you say it won't affect the rurals, but that is absolutely not the truth, because you're not creating really any more nurses in this bill. We have a finite amount of nurses. Those nurses and I'll address that in the next question I have about those that you say are out there somewhere. I really worry about the poaching of nurses that are in the rural areas, because you're not inventing any new nurses. How are you going to, do you feel that it won't impact other facilities and pull off nurses? Can you address that?
Thank you, Senator. Dakota Hoskins, Political Director for SEIU Local 1107, through the chair to you. And so I absolutely hear your concern. Our position, and the data backs this up, is when you have safe working conditions, you're going to bring in more folks into the healthcare space, right? So in states that have passed it, they saw their RNs. This in the first year of passing it, they were able to see their RNs grow by 60,000, and they had 60% more applications, and they were actually getting active RNs. So not just as you mentioned, we have nurses here, but are all of them active? I had their active RNs grow at 3x the rate what it was the prior year. So while this bill doesn't necessarily affect the county or the rural folks, and those ratios necessarily won't be in place there, we believe that especially in these, like in Washoe and Clark County, there's going to be more nurses coming into the state and staying in the profession than anything else we've done before.
So bringing those nurses into the state, that means you'll set the nurse compact and nurse reciprocity laws?
Yeah, so, sorry, Dakota Hoskins, Political Director for SEIU Local 1107.
I just thought I'd throw that out there.
Yeah, through you to the chair, or through the chair to you, sorry. Yeah, so I totally hear you on the compact. It's something regarding the compact does nothing to improve working conditions. If we bring in folks from all over the country, but we're still burning them out at a rate of 1 to 3 in 1 year, or over half at 2 years, are we really improving are we really maintaining, or are we continuing to lose nurses? And our position is we're going to continue to lose nurses, whether we train them locally, whether we bring new nurses in from out of state. If we do not improve the working conditions, that is the number one way to maintain and recruit new nurses. Other states that have done this have seen their nurses increase, not just from the people that apply, but also from other states as well. And some of those states also do not have a nurse compact. So,
And you'll share all that data, of course.
sure, yeah.
The statement that you made, somebody made about the amount of nurses, I think it's not somebody at the table, well, maybe it was you, that nurses that we know are out there, but they're not working. Where's that data coming from? Because as best I know it, when somebody lives in Nevada, we don't necessarily identify what their career was. So how do we know that there's a X amount of nurses just waiting to come back to work if we would pass this ratio?
Dakota Hoskins, Political Director for SEIU Local 1107, through the chair to you, Senator. I could be wrong. I don't know if anyone had quoted a specific set of data. More so, it was anecdotal knowledge of folks that they've worked with have left the bedside or planning or have left nursing altogether. I can work with you to see if we can find that information. I believe through different mechanisms we may be able to acquire some of that data for you, though.
So thank you for that. May I continue, sir? So I certainly know that during the COVID years, the nursing burnout was tremendous. Not only nursing, but healthcare providers in general. All of those people in the healthcare field that had the means to retire early did so. COVID drove a lot of them away from the healthcare field, not just nurses. But that doesn't mean that they're wanting to come back. And so I just really wonder about that kind of statement. If we do this, it's not like if you build it, they will come. I'm curious to see really if there's any data out there about people living here with active license, because the other issue I have with that, and you can correct me if I'm wrong, if you're not practicing, you have to maintain your license in order to come back and practice, right? So you could have a data set of what nurses have, and you could get that from the State Board of Nursing, that nurses that have an active license but that are not working. So that would be one data point that would kind of give some legitimacy to what you are saying. But if they gave up their license, that's a whole different ballgame. They're just because they're at home doesn't mean they could come back even if they wanted to do that. So I'd really appreciate some more data on that. So the bill doesn't address, it states a 100,000 population and a bed capacity, but it doesn't address whether it's a private hospital, public hospital, county hospital. I would assume that this would basically affect all hospitals that are out there, regardless of, county, public, private.
Thank you, Senator. Dakota Hoskins, Political Director for SEIU Local 1107, through the chair to you. Correct, it would apply to all hospitals that meet those population and licensing guidelines. Our view is patient care and quality patient care should not depend on which hospital you go to.
And do you have, thank you for that. Okay. So do you have any data, because you refer to other states, and so I'm really interested. I'm a data-driven kind of person. I want to see what the other states, if they've had these ratios, what the impact was. Really like to see those numbers, because one of my concerns is, are they really getting more nurses, or are they asking their nurses to work overtime? Because there is a true deficit on our nurse shortage here in the state. And so you pass a law like this, and while you're trying to get those nurses that have left the field, they have to get their license back, saying they even do, while you're passing that nurse compact and getting all those new nurses here, what happens with that? And when this passes, that now you're mandating this ratio, the hospitals don't have any more nurses. What about the RNs that now are going to be asked to work overtime because they have to fill this ratio?
I just wanted to address the first piece and what other states have. And
Name for the
Oh,
record.
sorry. Karen Yap for the record. I just want to address the first piece, which is regarding what other states have seen these ratios before. And so within the past 4 years since 2020, pending legislation or introduced, which includes the 2025 session, includes the states of Pennsylvania, Georgia, Maine, Illinois, New Jersey, Hawaii, and Connecticut. And then the states that currently have a version of ratios, there are some that are more comprehensive, such as Oregon, that has a very similar bill that kind of mirrors the legislation we've brought here today. So Oregon is the most recent state, and then other than Oregon, we have California, New York, and Massachusetts.
So thank you for that, because you have actually documented states who started this. Can you tell me where those states stand about the amount of nursing per population that they have compared to Nevada? Because I think those are the key things. It's one thing to implement a program if you have adequate nursing supply, totally if they're number 1 through 10 in ratio of nurses versus where we are, which was at the bottom.
Thank you, Senator Dakota Hoskins, Political Director for SEIU Local 1107, through the chair to you. That's a great question. I'm happy to work with you to provide that data. I don't have it in front of me at the moment, and I don't want to give you wrong information.
I very much appreciate that. Thank you. And Mr. Chair, I have a lot of questions, but the reality is it's going to be a long evening. I'm sure you have some questions, and I think I'm anxious to hear the rest of the presentation on both sides, and I can always reach out to them, and I'm really looking forward to some of the information I have concerns about. So thank you very much.
Thank you so much, Vice Chair Taylor.
Thank you, Chair. And I'll need to go back and watch the presentation. I was delayed in another meeting, so please forgive me. But I do have a couple of questions, and hopefully they won't be redundant in terms of something that I've missed. You talked a little bit about other states that have staffing ratios. Is there any information that shows that did their number of nurses go up as a consequence, or do you have any data or anything like that?
I'm sorry, Senator. It's the bleeding mic. Sorry. Here we go. Okay. Sorry, Senator. Can you repeat that one more time?
Sure. My question is that I know there are other states who have adopted nursing ratios, and I was wondering if there's any data to see or to show or demonstrate that then their number of nurses went up as a result of some of the things that, as I walked in, you were talking about working conditions and so on. Does that make sense?
Rochelle Wynn, I can actually answer that question. Thank you so much for asking it. Some of the corresponding documentation that was submitted to the committee that's uploaded on Nellis now has some of the citations that you can look at for this. But specifically, and I hate to keep going to California because we don't want to necessarily California or Nevada, but I think it's good to look at that state as opposed to some of these other states because their nursing ratios have been in place for a little bit longer. So we have more data to be able to pull from them. They saw their number of RNs increase by 60,000. In fact, their applications increased by about 60%. So the number of actively licensed registered nurses actually grew over 3 times the rate per year versus the years prior to staffing ratios being implemented. And to go back to one of the questions, and we are going to try to get that data for you, Senator Titus, is you had asked about the numbers. I don't want to discount the great work that we've done in combination with the hospitals, in combination with our institutions of higher education in order to increase the number of applicants. So I think it is really important to look at, and we got this from the National Council of State Boards of Nursing, the number of active RN licenses by state, and this is from December 2020 through February of 2025. Also documentation that you can follow up with on this, but I'm pretty sure in that documentation it talks about what your question was about how many people are not actually practicing that have active licenses. But I think it's important to say this, and I think it's something that we should celebrate as a state and as a legislative body because a lot of the decisions we made went into this, is we had a 26% increase in nursing active RN licenses since 2020. And so as of February 2025, it increased by 12,617 active RNs. So if we're losing any of those, we're doing the steps that we need to do. And I know that we keep talking about staffing ratios and we keep talking about this. It really is about nursing retention and patient safety. Those are the two overriding, things that we need to come back to. And I think if you have a great work environment, you are going to attract more people. We will get nurses. And just to what Mr. Hoskins said, you could have all the nurses in the world that are here, and if you have terrible work environment where they don't feel safe, they don't feel like they can fulfill their mission that they learned and their calling to become nurses, and they are seeing patients, they're losing patients that they normally wouldn't have to. They are not seeing people come back for readmission because they're able to care for them. You will see an increase in patient care and nursing retention.
Thank you, Chair. I'm going to follow up on that just a little bit. So much of the conversation, and really some of the conversations I had with people before the hearing, just regarding the bill, how currently, we're talking a lot about working conditions and so on, and the impact with ratios. How, right now in hospitals, how do hospitals now, how do they do things to impact ratios or working conditions, those things? Because as Senator Wynn said, we don't want to discount those efforts. So how, maybe you're the wrong, I'm sorry, you're the wrong one to ask? I'm sorry.
Sorry, Senator. Dakota Austin's Political Director for SEIU Local 07. I'm going to call on Jody to walk you through that.
It's great. You can always phone a friend. That's great. Thank you.
Hello, thank you for the question, Jody Dominic, for the record. Right now, there's always a goal of having safe staffing. That is everybody's goal when we do that. However, there is times when that doesn't happen, and there are ratios for, I work in pediatrics, so my experience is all kids. There are ratios for daycares, for adults per children in daycares. If those same kids get sick and need to be hospitalized, there's not a minimum amount. I've had to take care of 7 hospitalized children. I've had to take care of 6 NICU babies. If you can imagine how exhausting a newborn is, how care intensive caring for a newborn is when they are well. And now somebody with twins, and what that's like. I've had to take care of 6 NICU, neonatal ICU level patients, and tried to do my best. And I did try to do my best every single minute for those children. But there is not an activation. There are measures that are available. There are agencies, there are float pools, there are cross-training of additional nurses to be able to go between additional units. There are mechanisms in place that we can utilize to improve that staffing, because right now, while it is always the goal, it isn't always the reality, unfortunately.
And if I could just follow up, Chair, if that's okay. Rochelle Wynn for the record. I think that's one of the most telling things that I've heard over and over again from nurses is we have lots of areas where we have ratios, or we expect ratios, or we want to talk about it. Daycare is a perfect example. You have a certain level of adults to children that you need to have. When we are transporting prisoners, I just learned today that to transport a prisoner, you need 3 guards to transport that one prisoner. You have certain requirements that are in statute that are required when it comes to daycare of well children. We talk about, a number of students in a classroom of well children. And we're talking about a situation where if we go back to the initial example of 6 minutes, if you are caring for 6 sick babies in the NICU and you have 6 minutes to dedicate to each one of those patients, and that includes the time it takes to wash your hands, the time it takes to take vital statistics, you are down to like maybe 4 minutes on a best case scenario. If something should happen next door with another patient, another one of those sick child, that might cut into that 6 minutes that you're dedicated to that child. And that falls. I know that Senator Titus said that this was a very serious room because it's a very serious topic. These, predominantly women go into work every day wondering what kind of trauma they're going to have to face, how they are going to help their patients survive and thrive, and how they are not going to be burned out. And so, I think there are a lot of good things that we've done, and I don't mean this presentation to come off like there are any bad actors. I think everyone has that same goal. I think the hospitals are not in it to like not see this quality of care. And I want to continue to work with the hospitals and continue to work with opposition to see how we can solve this problem, how we can provide accurate patient care, and how we can, retain qualified, skilled nurses that are filling up this room, the overflow room next door here in Carson, and 2 rooms in Las Vegas. I think that's a testament to what they want to see in their workplace.
Thank you, Senator. If I may, thank you. I was late, so I got to catch up. Just how are the ratios determined? Did I miss that? Okay. How did you come up? There's got to be some best practices or something like that. How were they determined? Up, phone another friend. We really appreciate all of you being here, so thank you.
Thank you. Renee Ruiz again for the record from the chair to Senator Taylor. How the ratios are determined as far as with the amendment, the friendly amendment that is proposed. That took data and study, and I can provide you those exact studies, and I'm sorry I just don't have the paper in front of me right now, that determine because using data from 23 and 24, as opposed to when ratios first were implemented in other states in 2005. Massaging that data, looking at healthcare issues, looking at patient recidivism, looking at the acuity of patients, et cetera. That's why the ratios in the proposed amendment are what they are, where traditionally and in the original bill, there may have been 1 to 2 patients or et cetera down the line through the units. The increase of nurse to patients, because again, we're talking about minimums. We understand that like there are times that there will be more need for more nursing care per patient, right? So those ratios are thought through and brought through through years of study, collection of data, watching a process, and we have the years of research, and I can provide all of that from National Nurses United. There's a lot of it on our website with nationalnursesunited.org, but I also can bring the studies directly to you. But that is where we formulated the ratios that are more defined in the proposed amendment.
Can I follow up, Chair? Karen Yap, for the record, I also wanted to add on to that point as well. We looked at the ratios from the states that already have these different safe staffing mechanisms and national guidelines. So the 2 specific organizations we've listed is the Association of Women's Health, Obstetric and Neonatal Nurses, and the American Academy of Emergency Medicine.
Thank you so much. And Chair, with your permission, when we have that data sent to the committee secretary, then we can all have that. My final question, and Chair, thank you for your indulgence. In preparing for this and talking to people and so on, I was presented with a scenario, and I want to see how this would look. If you have ratios, right, let's say we pass this, ratios going and so on, what will happen if you fall below that ratios? Like if you have ratios in an emergency room, but somebody calls in, and so you don't have anybody, do you turn people away? Do you close the door? What happens when you're to a patient care if those numbers aren't met for one reason or another?
I'm going to phone a friend here because I know he can do a better job of this. It's like musical chairs.
Thank you, Senator. Dakota Hoskins from this side of the dais now. For the SEIU Political Director for SEIU Local 1107, through the chair to you. So currently, right now, hospitals already have different versions and different names, but effectively like a nurse float pool where they're kind of already accounting for nurses to make they're able to be cross-trained or put in different locations different units to be able to accommodate in case somebody calls out or any of that situation. So a lot of these measures and systems are already built in place to accommodate the care that hospitals are providing. So whether if someone called out or if a situation where somebody wasn't able to come in, they would have these float pools in process already and already functional. Additionally, currently, folks at different hospitals have what they call like bedside meetings where they work to figure out which nurses are short, which nurses need more, and they have folks that are on call that are available to be called in to do that. Additionally, many hospitals have contracted agencies that are able to provide additional nurses in times of emergencies or anything like that as well. So we believe that these mechanisms are already in place to provide this care, and so this would be it really should not be much of a difference than what they're already doing for these measures.
Follow up, please. So let's say for example, let's say it's an emergency room, and someone calls out, right? And then there are nurses on call and whatnot. But during that time period, before the other nurse gets there, they're out of ratio. What happens? That's what I'm trying to say. What happens? And there's a bus accident, and then you got 10 people. What happens?
Thank you, Senator Dakota Hoskins, Political Director for SEIU, through the chair to you. I'm not going to be the best one to answer, but I'll give you the quick answer, and then there may be someone that can touch on this further. But so, for example, like those float pools, those folks are already there. So they would just reassign them to those units. But in other terms of that, like you're at your point, let's say there is no float nurses in this situation, there's none available to be moved, right? They're able to bring people over. That's also why with the legislation, the language that we use, the Labor Commissioner is allowed to investigate these allegations, but there's also the Division of Public Behavioral Health may implement some of these disciplinary measures. They're not mandatory. Right. So, I think there's different situations that would be up to the division to see how they would want to apply those. I can't predict how they would, but we understand that there's going to be times where folks are going to need to fluctuate. And so, like I said, we believe that the current measures already in place for the hospitals use to assign nurses will be sufficient. But if somebody else is interested in walking through like a day-to-day example, that's fine too.
I think that's sufficient. Okay, thank you so much. Thanks to all of you, and again, Chair, thank you for your indulgence.
Thank you so much. Now it's my turn. Got a lot of questions. I think I have like 14, so we'll see how far I go. Knowing that we're trying to get out of before 6, we'll see how that happens. First and foremost, just more commentary, right? Obviously, the same comments that we've heard from our committee members, right? We want to thank the nurses that have come out here in support of the bill, right? Regardless of where we align in terms of the policy, I think we're all just very appreciative of the narrative of the conversation of at least protecting patient safety and making sure that we're able to serve the needs of the state. I think all of us are on the same page with that. And I do want to mention, peer-reviewed research does show that adequate staffing does lead to the reduction in hospital-acquired infections. That is proven, right? We're all in that. That's not a notion to be debated. That has been pre-established for 20 plus years, right? But on the same page, I feel a little bit divided as someone who's a health administrator, right? I can see scenarios where we don't want to put ourselves in positions where we desperately want to provide and open up our services to patients, and we want to serve their needs. And I'm fearful that if we don't meet the demand, right, as to what the things that we can't have out of our control as health administrators, right, how do we respond to that? And what I mean by particularly, right, is, as a healthcare administrator, and I work in primary care, if there was a law to be passed on, say, the coverage of medical assistants, right, it's very different working on the operations on the floor, right, in the morning, right? We've been in circumstances where we wake up at 5 a.m. trying to move people around, and so I guess the premise of this is what I don't want to have is I don't want us to be in a position where we're having to close units because we have to respond to an emergency or uptick. So maybe let's start from there. How can we deal with circumstances where an emergency or declaration is made, and are you open to amendments to at least reflect that these ratios can be flexed or waived in times of an emergency? Is that something that you're open to?
Thank you, Senator Dakota Hoskins, Political Director for SEIU Local 1107. Yes, that's a great question and something we're definitely open to looking at, whether it be declaration of emergency, whether it be a mass casualty incident, whether it be some type of crisis. I think we're definitely open to looking at different ways to make sure that we can still make sure Nevadans are cared for, and attempt to do our best to still maintain health and health safety for folks.
Thank you. I want to move. Senator, were you going to say something? Oh, sorry.
I do see this as a dynamic process, and I think anyone that's like worked with me on different pieces of legislation over the last four legislative sessions that I've had the honor to serve on this body and recognize that. I think some of the difficulty that we've had now is you can see we have had proposed amendments because those are people that are willing to come to the table and talk to us about things that we think we could do. We are definitely open to having those conversations about crises or states of emergencies or any of those concerns that we would have. Even implementation dates. I know that in the bill as written, it implements October 1 of 2025, and we can have those conversations. But right now, I'm just kind of negotiating with myself, and so the people that have an interest, that want to have those kind of conversations about what would make this a better bill? What would make this be able to accomplish our goal of making patients safe and retaining our nurses? They need to come to the table and have those conversations with me. Otherwise, I don't know. And you can see we've had conversations with the labor commissioner. We've had conversations with our rural partners about what can make this better. Even though they're currently excluded, they had those same concerns that they expressed. So we are definitely open to having that dynamic conversation about what can make this a better bill.
Thank you, Senator. Yeah, I think the rationality as to what I was trying to mention was I know Section 12 and 13 of the bill deal with more of the repercussions of the alleged violation, and so I guess the reason why I was asking that was as a health administrator or as a manager of your unit, right? There's only so many things that you can control, and so as long as you're doing the best to the extent that you can, right, then that should be preserved as part of this bill process, and that includes the emergency provision. So I'm glad that you guys are considering that. I want to talk more about the technicality of the bill, more and less so of the nature of whether or not to do it. But on Section 8, there's a reference to 70 beds. How was that determined in terms of the bill? 70 beds is usually the small hospitals, and so I know states have looked at maybe applying this to medium-sized hospitals or some of the larger ones so that the small hospitals aren't put in a tough financial position. So where did that number come from?
I think Ms. Ruiz Rochelle Wynn for the record, kind of alluded to this. We have the backup data for the states. I mean, part of being in a position where we're not the first state to implement these, we've been trying to work through what works well, what works better, I guess, in some of these other states, and coming up with some of these determinations. In addition to that, the way that we were able to do this is take some of the best practices from these other states that have nursing and staffing ratios already in place, and we also talked to the people that are on the ground, the people that are filling this room, filling the room in Las Vegas, filling these overflow rooms. They are the ones that we are listening to figure out what we can do better. I'll be honest with you, there are hospitals that are doing this better in our own community. I always look at pieces of legislation that you are wanting to expand statewide. We have perfect incubation things. A lot of times we will look at if a city is doing well, and we're like, this is a city policy that's working really well. How can we expand this on a more statewide level because it's working? I'm going to call out them because I think they're coming here in opposition, but Dignity Health and Dignity Hospitals have great examples and things that we took and incorporated into this bill because we know that they are doing it right. They're implementing process and procedures in place and staffing ratios in place that are retaining their nurses. They are retaining their medical staff, and they're providing quality care. So these aren't things that we just came up with numbers just out of whole cloth. We are looking at what we are doing right in our state and how we can expand that to provide those same kind of benefits to patients and nursing staff across the state.
Great, thank you so much. Now dealing with another technical aspect of the bill. So obviously we're laying out the 1-to-1 direct ratio for certain units and so forth. And then obviously in the amendment, there's that it is extended and so forth. Is there flexibility in terms of giving the oversight committee more authority to make the determination as to what is appropriate, or would it just be falling onto statute, I guess? So if it says 1-to-1, but the staffing committee says, okay, we're kind of facing a tough time right now, there's a lot of flu cases, maybe it's 1-to-2 is okay for right now, does the oversight committee have the ability to supersede state law, or is this the way that this is written, it's only the only thing that would be allowable is what's in that section?
Rochelle Wynn for the record. I mean, as written in this friendly amendment, the statute overrides any things. But that's a perfect example of where if we had more participation in the process in creating these amendments, we could come up with more language that maybe gave more flexibility in emergency situations, or was responsive to these committees that these committees that are formulated to address these on, a hospital by hospital level. And so it's definitely where again, we are definitely open to discussing this. We want to make this a better bill. Like I said, patient safety and nursing retention are our two main concerns.
Thank you. And the only thing that I just made a note for is, obviously we talk about like best practices, and from my research, a lot of this, I'm assuming it's part of the research that helped you make the determination for this bill. A lot of it comes from the standards of the American Nursing Association and so forth. And so there is a precedent of it's coming nationally as well, right, as to what you wrote. The other thing that I'm more concerned about doesn't talk about this, but like what's the circumstances of egregious understaffing, right? In other industries, I know there was you took it out more on the SNFs and nursing homes. That's usually where we hear a lot of the concerns, right? That's why the Biden administration made the level of standards just last year. And so just something for you to think about later on as we're going through this process. So I don't have any other further questions. I think we're ready to do testimony if that's the case. So thank you so much. And we'll go ahead and open for support testimony. Once again, it's going to be limited to 2 minutes. We want to make sure as many folks get the chance to participate, and so we ask for not repetition, right? Folks are okay to say ditto. We're going to go back and forth with the flexibility. So again, this is support testimony on this bill. So we ask for folks to please come forward in Las Vegas and in person, and then we'll also flow for folks that are watching virtually as well. And we will put 30 minutes on the clock, so we'll stop at 5:30. So let's go ahead and begin with the clock. So let's start here in Las Vegas. Please proceed.
Buenas tardes, delegado, miembros del Comité de Salud y Servicios Humanos. Mi nombre es Marisela Sandoval y soy miembro de la SEIU 1107 desde hace 16 años, trabajando en elegibilidad financiera en un hospital público del Valle de Las Vegas. Estoy aquí para testificar en firme apoyo a SB 182 porque las proporciones de personal seguro no son solo números en un papel, sino una cuestión de vida o muerte tanto para los trabajadores de la salud como para los pacientes a los que se atienden. Cuando los hospitales no tienen suficiente personal, nuestras enfermeras, técnicos y otros trabajadores de primera línea están al límite, lo que provoca agotamiento, errores y que los pacientes no reciban la atención que se necesitan. He hablado con trabajadores de la salud que aman lo que hacen, pero están exhaustos, sobrecargados y sienten que no pueden seguir el ritmo. Esto no solo les afecta a ellos, sino a todos nosotros que dependemos de ellos cuando necesitamos atención médica. SB 182 trata de proteger tanto a los trabajadores como a los pacientes. Significa una mejor atención, tiempos de espera más cortos y un sistema de salud que realmente funcione para los nevadenses. Les debemos a nuestros trabajadores de la salud y a nuestras comunidades asegurarnos de que tengan el apoyo que necesitan para hacer su trabajo de manera segura. Insto a este comité a que apoye SB 182 porque cuando cuidamos a nuestros trabajadores de la salud, ellos pueden cuidarnos de nosotros también. Gracias por su tiempo.
My name is Sharon Renee Savoy Duraso, for the record. I work in healthcare. I'm not a nurse, but I'm a senior point of care analysis in a laboratory, and I see how it affects the nurses in our area and in the hospital, and I work for Dignity Health for 20 years right now. Also, too, I'm with SEIU Local 1107, Executive Vice President of Private Sectors. I see and I do support the SB 182 bill because of the fact is every day we see how everybody's job is being the nurse's job. The nurses is taking upon themselves, not upon themselves, but management, administration has given them everybody else's job to go ahead and do besides patient care. It's affecting patient care real bad. Every day, it's an emotional, also too stressful day going to work when we're all at odds with each other because of the fact is you have these patients that's fighting us. You have patients that's, in other words, I know you guys, y'all listen to the stories. You have to be there to go ahead and participate in what we go through every day. We try to be team partners, but it's very hard. These patients is not getting turned on a daily basis, not getting turned over. They're not being taken care of. Also, too, that we always do a survey twice a year, asking if we want to come to our own hospitals. And you know what I tell them? No. Because of what goes on behind closed doors, regardless of administration, regardless of everything. That's the reason why I support this bill. It's not a joke what we go through every day. We getting up every day trying to do the best that we can as healthcare workers, regardless whether we're a nurse or not. But everything is getting put to the nurses, and it's wrong.
Thank you, ma'am, for your comment. Unfortunately, we've reached the time limit. If you can wrap up your comments.
Yes.
And can you spell your name for us for the record, please?
SHARON. And you need my last name also too. S as in Sam, A V as in Victor, O Y hyphen D as in David, URISSEAU.
Thank you, ma'am.
You're welcome.
Hi, my name is Helen Cornelius. I'm a registered nurse representing National Nurses United. I have been a nurse in Nevada for 18 years, working in labor and delivery that whole entire time. I am here to support Senate Bill 182. Sorry, I get emotional. Since becoming a nurse 18 years ago, the demands and expectations on nurses have increased exponentially. Our patients are sicker. The charting that's expected of us from administration is more in depth and more. There's just more and more regulations, more things being asked of us. As a professional, I pride myself on giving the best evidence-based care to each and every single one of my patients. As such, I'm an active member of my governing agency that sets the standards for pregnant persons and newborns since the year of 1969. In 2010, they set a standard for staffing ratios for nurses. No Southern Nevada hospital follows these standards. None. And let me make it very clear that these standards are also endorsed by the American Academy of Pediatrics and the American College of Obstetrics and Gynecology. It's time for Nevada to step to the plate and enforce these ratios to ensure safety for our patients and work satisfaction for my peers, who, by the way, keep leaving the bedside when they find out how hard it is to be a labor and delivery nurse. Because it sounds like fun, doesn't it? Seems like it should be a great place to work. This all being said, I'd like to say that my mother-in-law was also hospitalized in a Southern Nevada hospital and was left on a bedpan for 4.5 hours. 4.5 hours, people. for a woman with dementia. We need to keep this bill going so that we can keep experienced nurses at the bedside and to incentivize those nurses who left due to emotionally hazardous working conditions to return to the bedside. And yes, I know a lot of those nurses. Thank you. And most of them are very young. Thank you.
Thank you so much. Let's go to Las Vegas.
Buenas tardes. Good afternoon, Chair and members of the committee. My name is Yarleni, for the record, Y-A-R-L-E-N-Y, last name R-O-A-D-U-G-A-N. I am the current Secretary Treasurer for SEIU 1107, and more importantly, I'm a registered nurse of 11 years in working in Nevada hospitals, public and private. And I am here today to strongly support SB 182 because I have seen firsthand how inadequate staffing puts both patients and nurses at risk. When nurses are stretched thin, patient care suffers. I have personally witnessed near misses, delays in treatment, and preventable complications simply because there weren't enough nurses available to provide the care our patients deserve. This is not just a workplace issue. It is a patient safety crisis. Studies have consistently shown that safe staffing ratios improve patient outcomes, reduce mortality rates, and prevent nurse burnout. Research published in The Lancet and Health Affairs proves that hospitals with appropriate staffing experience fewer complications, shorter hospital stays, and lower readmission rates. Additionally, proper staffing leads to better nurse retention, reducing turnover, and ensuring experienced professionals stay in the field. Nevada has the opportunity to protect both patients and nurses by passing SB 182. This bill is not just about numbers. It is about saving lives. I'd like to think that I have the privilege to work in the happiest place of the hospital, labor and delivery, like the previous nurse mentioned, where we celebrate birthdays every day. However, not having safe staffing ratios means I can't educate and support a new mom that wants to breastfeed the rainbow baby. That means a baby that was born after a miscarriage. Not having safe staffing ratios mean I can't reassure and support a patient during their labor.
If you can please finish your comments, please.
Yes, not having safe staffing ratios could mean that I don't have enough hands to push a bed out of a room to make it to the OR on time to save a baby's life, or even the mother's. So I urge you to support this legislation and make patient safety a priority. Thank you.
Thank you. Next person in Las Vegas, please.
Good afternoon. My name is Jezamay Arevalo, Jezamay, Arevalo, Arevalo. I'm a certified nursing assistant in Dignity Health St. Rose Hospital. It used to be Dignity Health, but now it's Common Spirit. I'm one of the float pool CNAs, and I go to all the campuses and units all over Las Vegas and Henderson. Just FYI, one of the units or three units in the hospital, well, a lot of the units are out of ratio all the time. For example, intermediate care, 36 very sick patients, one CNA, 12 hours a day and night. 24 patients, one CNA, 12 hours a day and night. Intermediate care are the patients from ICU who almost lost their lives. And now they could die because the nurse or CNA cannot attend to them. I'm just gonna give you the calculations of 12 hours, 20 hours, divide 36 patients for a CNA is equals to 20 minutes, the whole shift. If your family member is dying and your family member can't be turned, Your family member could die because of blood clot, pressure, hospital-acquired pressure ulcer injury. Your family member can fall, and because of that fall, it they could get a traumatic brain injury and they could die too. Your family member is not gonna get CHG bath. That's prevent blood infection, and they could die too. So 36 patients in INC care, 1 CNA on the floor, has higher risk of dying. Patients. And I know my time is up. Thank you.
Thank you. Well, let's do one more in Las Vegas, please.
Good afternoon, Chair and members of the committee. My name is Melly Paluay, Mellylpauay. I have been a registered nurse licensed in Nevada since 2017, and I am here today in strong support of SB 182. As a medical surgical nurse who has worked in neuro and step-down units, I have regularly cared for 6 or more patients per shift. The Lancet reports that when a nurse's workload exceeds 6 patients, the risk of death increases by 7% per additional patient. How is one nurse supposed to provide safe and effective care for 6 patients when a regular shift for us looks like patient 1 is actively pulling out their IV during a blood transfusion, spilling blood on the floor while 3 staff members struggle to keep them from harming themselves. Patient 2 is on his 9th 3-liter bag of continuous high-flow bladder irrigation, which must be changed every 15 minutes to prevent excruciating groin pain. Patient 3, who is suffering from malignant bone cancer, is overdue for his pain medication. And meanwhile, the lab is calling about a patient 4 whose lab results show a critically high ammonia level, which can lead to hepatic encephalopathy and neurotoxicity due to his liver cirrhosis, which explains why he is behaving erratically and spreading feces on the wall. Patient 5 is having an allergic reaction to a newly introduced medication and needs an urgent transfer to critical care. And patient 6's family is demanding assistance immediately because he just had a bowel movement. This is not an exaggeration. This is a reality. This is the impossible situation nurses face every single shift due to unsafe staffing ratios. When we are stretched thin, patient safety is compromised. Delays in care can mean the difference between life and death. Medication errors increase, preventable complications occur. Nurses are forced to choose between urgent needs, knowing that no matter how fast we work, someone will suffer the consequences of an overwhelming system. Beyond patient safety, unsafe staffing is a leading cause of nurse burnout and nurse suicide. The Journal of Nursing Regulation found that 80% of nurses who reported they were burnt out cited unsafe staffing as the primary cause. The American Nurses Association reports that nurses are at a significant higher risk of suicide compared to the general population. Female nurses are twice as likely to die by suicide, and male nurses are 41% higher
Ma'am,
risk
if
to
you
die.
can please complete your remarks.
Yes. Yes. I urge you to pass this bill. Nevada nurses and patients deserve better. Thank you for your consideration and time.
Thank you. Let's hold on. Let's refrain from clapping, please. This is not a. I just want to make sure that we're respectful to everyone attending. Let's go to AVH if we can do 3 callers online, please.
If you would like to testify in support of Senate Bill 182, please press star 9 to take your place in the queue.
Good afternoon, Chair Dunyadi and members of the committee. For the record, I am Matthew Parker, M-A-T-T-H-E-W-P-A-R-K-E-R, representing the Brotherhood of Locomotive Engineers and Trainmen in support of SB 182. As someone who required intensive care due to a serious illness almost 20 years ago, I have the utmost respect and appreciation for hospital staff at all levels and the part they played in healing me. Adequate staffing is a key component of quality patient care. This bill will help further assure that the voices of the professionals who know best are included in making staffing decisions. Further, we often hear from industries when legislation potentially imposes additional requirements on them that these decisions should be data-based. This bill will help to assure that you as legislators have appropriate data when determining the need for public policy related to the quality of patient care for Nevadans. I therefore urge you to join me in support of this bill. Thank you.
Caller with the last three digits ending in 369, you are unmuted and you may begin.
Good afternoon, Chair and members of the committee. My name is Kayla Maese, spelled Kaylah, last name Maese. I'm a civil rights analyst at the ACLU of Nevada. This bill ensures safe staffing ratios, ensuring healthcare professionals have the support they need to provide the highest quality care for patients. By preventing excessive workloads, this bill helps reduce burnout among our crucial healthcare workers and ensures patients receive the adequate treatment they deserve. We thank Senator Wynn for carrying this legislation and the Service Employees International Union, Local 1107, for their unwavering commitment to advocating for their members' best interest. We urge the committee to support SB 182. Thank you so much.
Good afternoon. My name is Joseph Graham, JOSEPH, I'm a chief steward for CWA Local 9413. I strongly urge the committee to support this bill. Thank you.
Thank you so much. Let's come back to Carson City, please.
Thank you, members of the committee. My name is Elizabeth Bickle, Elizabeth, B as in boy, Ickle. I've been a registered nurse for 19 years, and I work in the emergency room currently at St. Rose San Martin in Las Vegas, Nevada. I support SB 182, Nevada Safe Staffing, because we need safe staffing in order to provide our patients with the best of care. And we already know that safe staffing saves lives. We were asked to think about a story or a situation that really struck us when we were addressing you today. And the one thing that came to me is there's not one story that stands out. There are stories that happen every single day. And when Jody was presenting the bill, she talked about only having 6 minutes per patient per hour to care for these patients sometimes. I work in the emergency room now, but I also used to work on a very busy surgical step-down floor. And the thing is when things go wrong, and after surgery, things so often do, that the care that you end up giving your patient that takes more than 6 minutes, and those cares do take more than 6 minutes, then take away the care from the next person down the line, and the next person down the line, and the person down the line after that. So I think my one example would be I had a post-op surgical patient who had had extensive, multiple gastrointestinal surgeries. Things were outside that should have been inside, let's put it that way. And she had bandages that, because of her skin condition, would not stay in place. I spent an hour and 22 minutes in her room, changing those bandages, doing that wound care, nonstop. And who was watching my patients during that hour and 22 minutes that I couldn't be out there with eyes on them, because my patient needed my complete and utmost attention for that time period. And so what I'm asking is
if you can please complete your remarks.
Yep. Please consider this bill, because we know safe staffing saves lives, and our nurses deserve this, and so do our patients.
Thank you, Chair. For the record, my name is Susie Martinez, and I am the Executive Secretary Treasurer of the Nevada State AFL-CIO. We are in full support of Senate Bill 182. You know, I just want to thank all the nurses for all their hard work, but let's take it one step further. Heaven forbid that any of us in this room end up in one of the hospitals. We want our nurses to be rested. We want them to be ready to work. We don't want them to be burned out, right? We don't want to be sitting there one day saying, you know what a goddamn shame that bill did not pass. So for that, we are in support, and thank you very much. Thank you, nurses.
For the record, my name is Mark Ellis. I'm the President of Communication Workers of America, Local 9413. We support, if you're not a nurse at St. Mary's, you're one of us. And I'm going to be extremely brief so people with more important stories can come up and talk. We strongly support this bill.
Thank you. We'll do Michelle, and then we'll go back to Las Vegas, please.
Good afternoon, Chair, Vice Chair, members of the committee. Thank you so much. My name is Michelle Mayese, Michelle-Maese. I am the president of SEIU Local 1107. We represent 20,000 workers in Clark County, Nevada, and here in Reno. So I just want to thank you to our bill sponsor, Senator Wynn. Thank you to our nurses and healthcare workers who live day in and day out with the fear of losing a patient, losing a loved one, and not being adequate enough. You heard that they said that they felt like they failed Nevada at times. And so I thank them for our labor brothers and sisters who came up here. I just want to make no mistake about it. We do not have a shortage. We do not have a nursing shortage. We have a dignity, respect, and safety shortage, period. And this bill is just the beginning to turn that around for the state of Nevada. And listen, we also don't need a nurse compact. We don't need other nurses coming into our state to care for our community when we can implement safe staffing ratios for our nurses here in Nevada so they can take care of our own, period. So we're excited for this committee that you have the opportunity to lead the state of Nevada in providing safe staffing ratios for our nurses. We appreciate you hearing the stories of our healthcare heroes, our essential workers, our frontline workers who work day in and day out. And we believe that the thank you is an action word. So we look forward to the action that you will take by supporting this bold legislation of safe staffing to save lives. Thank you.
Thank you. Let's go down to Las Vegas, please. You may begin.
Good afternoon, Chair and members of the committee. Geo Hughes for the record. I'm an acute care nurse practitioner and currently a healthcare administrator. I'm testifying in support of Senate Bill 182. Something that is sometimes lost when we talk about ratios is that ratios allow us to take care of patients in the way they need to be checked on. A 1-to-1 ratio means, as an ICU nurse, is that we have to check on those patients every 15 minutes sometimes, and every 5 minutes sometimes, because we're titrating. That means we're adjusting medications that are life-saving, that keep blood pressures up, that keep heart rates up, that keep the patient asleep enough so that they don't pull out a breathing tube that's keeping them alive. So when we talk about a 1-to-1 ratio or a 1-to-2 ratio, we cannot lose sight of that. It is so that we can adjust those medications, we can take care of those patients to save their lives. Bottom line is that the nurses have been taking care of patients regardless of the numbers that we are given. I say we because, first of all, I'm a registered nurse. What is hard to understand is that while we are told that we are short-staffed or that there's not enough nurses, is that we're still opening wings in hospitals. Let's be held to the quality, not the quantity. Let's say that again, the quality, so that we can provide safe, life-saving support. So we're asking you to please, please support these nurses so that we can be held to the quality and humanity that we want to offer our patients. Thank you very much.
Good evening. My name is Catherine DeMaya, for the record. I'm a resident of Las Vegas and a registered nurse. I'm here today to advocate for nurse retention and act as a voice for every patient, especially those who are no longer with us and unable to advocate for themselves. In response to Senator Titus inquiring regarding where the nurses have gone who have left the field, they are here in this room and included in the 900+ Nellis bill comments advocating for the quality of patient care standards. I would implore you to review them following this meeting. If this bill passes, many other nurses and myself personally pledge to return to the bedside knowing that our licenses and livelihoods no longer will be threatened every shift, just as it was when I left the field in October of 2024. I'm here to testify in support of Senate Bill 182. I left bedside nursing after 2 years of working in the intensive care unit because I was forced to work outside of medically recommended nursing ratios, and I experienced firsthand the detrimental outcomes caused by unsafe staffing ratios. I was forced to watch patients die, needlessly suffer, or become disabled, and question if it could all be prevented. This absolutely could have been prevented. Our community has faced huge suffering, grief, and ultimate loss because of the negligence forced upon them due to a lack of staffing mandates. Nurses are forced to take almost double the amount of patients that we can physically handle, and being asked to sacrifice the quality of our work and therefore the safety of our patients. This bill gives us a voice and allows us to advocate. Our working conditions as of now are not sustainable and will not improve without serious legal reform. With this legal reform, we will be able to improve the working conditions and help increase nursing retention. Please advocate for us so we can care and advocate for you. The lives of our community will continue to be determined by corporations, not healthcare providers or medical professionals, without this legal action. We have zero legislative protections for nursing staffing ratios in
Ma'am,
Nevada.
if you can please complete your comments, please.
Of course. Please, I implore you to please advocate for us so we can care for you as nurses. Thank you.
Thank you so much. We have time for 2 more, so I'll take one in Las Vegas and then I'll take one in virtual. So please begin.
Hello, my name is Dr. Robert Bush, president of the National Action Network in Las Vegas. For those that don't know, it's the organization founded by Reverend Al Sharpton, and we are proud partners of SEIU 1107. And I am here to show our support for SB 182. First, let me say to Senator Titus that this is serious, and that we're serious here because lives and livelihoods are at stake. And it sounds to me like you may be talking a little bit from your privilege.
Excuse me.
This is a decisive moment for our healthcare system in Nevada.
1 second.
Nurses
One second,
facilitate.
sir. Before you begin or continue, we cannot disrespect the members like that. So I would ask you to please refrain from doing so. You can continue.
This is a decisive moment for our healthcare system in Nevada, and nurses facilitate the entire healthcare journey from hospital admission to discharge. This role gives them a unique perspective and power to drive positive patient outcomes. Appropriate staffing levels have multiple benefits, including reduced mortality rates, reduced length in patient stays, reducing a number of preventable events such as falls and infections. And nurses are at the forefront of our healthcare system. By recognizing the true impact of nursing, you can lead the change that will both address the nurse staffing crisis and also improve healthcare for everyone. The state of Nevada in 2009 passed SB 362, Patient Protection and Safe Staffing Bill. This legislation requires hospitals to have staff committees that oversee nursing staff and implement policies to ensure safe and appropriate patient cares. I believe that this legislation and this requirement was meant to improve patient care by increasing the hospital oversight of the nursing staff. But what it did was it put a roof on a building without laying the foundation, and the nurses are the foundation. I urge this body to follow the example of our neighbors in California and take action.
Thank you so much, sir,
to
for your
put a
comments.
law in place.
You have reached a time limit.
Yes.
Let's go ahead and AVH, if we can go one more virtually, please.
Good afternoon, committee members. Thank you, Senator Rochelle, for introducing SB 182. My name is Dr. Fan Nguyen. Last year, I was a patient at Summerlin ICU for 6 days. Those 6 days were the longest days of my life, but my nurses did their best to help me recover. Throughout those long days and nights, my nurses were constantly going from room to room to room to treat patients while maintaining the highest quality of care. I knew they were worn out due to being short-staffed, but did the utmost to comfort me throughout my stay. There were nights when I cried because I was worried I may not be able to be home with my wife and children. My nurses were there to help me wipe my tears away and assured me I would recover and thrive. I found a newfound respect for nurses and see the difficulties they go through daily when there are not enough staff. As such, I urge you to support SB 182. Thank you.
Thank you so much. That concludes this round of support testimony. So for the folks that did not get the chance to participate, we ask for please, you can always submit your testimony in writing to us and we can go ahead and upload it. So that goes for anyone here in Carson City or Las Vegas. Before we move on to opposition testimony, again, I want to reiterate that part of this process is for all of us to hear each other out, whether we're for or against the bill. And so I would ask for folks both here and in Southern Nevada, and it's not really much out online, but to please remember to not clap or cheer or make jarring statements, especially to those that are testifying one way or another. Otherwise, we lose the point of the process. And so I just wanted to make sure that's clear. Otherwise, we do have to get security involved, and I don't want to get to that point. So let's go ahead and get our opposition testimony. We are going to start first, as I mentioned, with the presentation, and then we'll go ahead and move on to the timed opposition. And Mr. Kelly, you can proceed when you're ready.
Thank you, Mr. Chairman. My name is Patrick Kelly, K-E-L-L-Y. They were asking me my microphone was loud enough, but it's on. So, and I'm with the Nevada Hospital Association. So I want to share with you 5 reasons why you should vote for no on this bill. And there are many more than 5 reasons, but in the time I have, that's what I'm going to try to cover. So the first is Nevada has a severe nursing shortage. SB 182 requires hospitals to hire nurses that don't exist. It defies reality. Nevada ranks 46 in the nation for nurses per capita. You've all seen the statistics of how many nurses are needed to meet the national average. And keep in mind, 40% of Nevada's RN licenses are held by nurses with an out-of-state address. I think that indicates that the shortage is even greater than many think. By 2030, Nevada will be among the top 5 states projected to have the most pronounced nursing shortage in the country. Number 2, Nevada has a fragile health care delivery system. You all heard it a week ago when we were talking about Medicaid cuts. Everyone talked about the fragile health care delivery system. We know that millions of Nevadans live in federally designated health professional shortage areas. A couple of examples of how bad our health care delivery system happens right at hospitals. In our emergency departments, many people come for primary care services, and they should not be doing that. And that's because we don't have adequate primary care in our communities. Law enforcement brings behavioral health patients to the hospital who do not have a medical condition and should not be brought there because there are not behavioral health services available in the community. Additionally, hospitals can't discharge patients who are medically cleared for discharge. We have a very difficult time moving them out of the hospital. And so what's going to happen with all these people who really shouldn't be in the hospital, we are now going to have to staff them at heightened staffing ratios. Number 3, SB 182 would place a huge burden on hospitals. We surveyed our members, and while we didn't get 100% return, I will share with you, as of January 1st, 2025, we had open positions for 780 RNs, 33 LPNs, and 239 CNAs. We're still using traveling nurses to cover our shifts. To meet the mandatory nurse staffing ratios, we estimate that it will be about more than 1,500 additional nurses that are needed. We can't find the 780, and now we're going to be asked to come up with 1,500. And as I said, not all hospitals reported, so that number should be higher. The cost annually, the cost will be approximately $188 million, and that's not counting the CNAs that are required in the bill. And if we use travelers, which we probably will have to, we will be looking at $240 million plus the cost of the extra CNAs. Keep in mind that patients in our hospitals, we have about 78.5% of our patients who pay less than the actual cost of care. And then this additional burden is going to come on. And then if you look at what's happening on the federal level, we're looking at the potential for massive Medicaid cuts, and that's going to be extremely burdensome. We project that 956 beds would close daily if no new nurses were available, and over 109,000 patients would not receive care annually. So to remain sustainable, hospitals will have a few options. They can hire travelers, close beds and/or services, and divert ambulances. And all these things did occur in California. And worst of all, we're going to have to reduce capital investment. And here we have a hugely growing population in our state that those needs won't be met. The top three risks, three services, at risk of closing are maternal and infant health services, specialized critical care services, and behavioral health services. These are all things that we have been trying to improve in Nevada. Reason number 4, the impact on other healthcare providers. Critical access and other hospitals outside of Clark and Washoe counties will be impacted by this bill. We saw it during COVID when there's a demand for additional personnel in Las Vegas and Reno. We have nurses who leave their rural communities and come down and work as traveling nurses. Ambulance services will also see an impact because they're going to have delays at emergency rooms. Post-acute providers such as nursing homes, home health, behavioral health, hospice, palliative care, they will all feel the impact of this. We already know that nursing homes in particular have a difficult time staffing and keeping all their beds open. That's one of the reasons we have difficulty discharging patients. Public health and federally qualified health centers will also feel the impact. Basically, anyone who hires nurses will be impacted by this bill. Number 5, Nevadans will lose access to health care, and this is the most important. In hospitals, patients will not be able to move to the appropriate levels of care if a nurse calls off. Emergency departments will become blocked, and ambulances will be diverted to a lack of staffing. Ambulances will not be available to the community as they're sitting and waiting and having longer patient offload times while we're waiting for a nurse to become available. Patients will not be able to access post-acute care services. I want to share with you just a couple of scenarios for you to consider. In surgeries, you're scheduled for a life-saving surgery to remove a tumor. On the morning of the surgery, you receive a call saying it's canceled because a nurse called in sick, and the hospital cannot meet staffing requirements in the post-anesthesia surgical unit. Your surgery cannot be rescheduled for several weeks, and your tumor grows. The bill requires a 1 nurse to 1 patient in the operating room, but in the post-anesthesia unit, it's 1 nurse to 2 patients. So if that 1 nurse is not available, that's 2 patients who cannot be taken care of. Scenario 2, labor and delivery. You're scheduled to be induced for labor, but a mother expecting twins arrives unexpectedly in active labor. Other mothers arrive at the hospital in active labor. You're sent home because the hospital cannot meet the mandatory staffing ratios. So in this bill, active labor is 1 nurse to 1 patient, and we know active labor can go on for hours. Labor and delivery ratio is 1 nurse to 2 patients, and the mother and the baby are considered different patients. So if you have multiple births, you're going to be really tying up 1 nurse who will not be available to take care of other people. Scenario 3, an ambulance transport. You're experiencing a heart attack or a stroke. The ambulance takes you to the nearest trauma center. However, the trauma center is on diversion because it is short just 1 nurse, and you are diverted to another hospital. Time is of the essence, and your care is delayed. Trauma care is 1 nurse to 1 patient, and other ED patients are 1 nurse to 4 patients over each 12-hour shift. So if an ambulance comes in, you've got to get 4 patients out of that emergency room for that 1 nurse to be able to take care of the trauma patient who comes in. So the bottom line is this. If you're concerned about access to health care or the cost of health care, please vote no on Senate Bill 182. Thank you.
Thank you so much. Committee members, do we have any questions? No? I got one. Really quickly, how familiar are you with Joint Commission standards? You're pretty familiar with them? Do hospitals generally, and I know there are hospital folks here, generally do we try to follow accreditation standards offered by the Joint Commission? Is that generally where we look towards for best practices?
Yes, Senator, Patrick Kelly, that is who we look to. Most of the hospitals are Joint Commission accredited.
Great, thank you. So the reason why I was asking that is, so it's my understanding as part of the Joint Commission accreditation standards that there are provisions that deal with staffing plans, staffing considerations, staffing scheduling. And so I guess the question is if all of us are adhering to the quality metrics and its staffing standards that the Joint Commission already has as part of our accreditation, then like what are those standards? So from my recollection and based on my own work experience and research as well, it's my understanding that for as prescribed by the Joint Commission, that med-surg is their ratio is about 1 to 4 to 5, right? So that's for med-surg. The intermediate units are 1 to 3 to 4, and then ICU is 1 to 2. So that obviously that's different from what the bill proposal is, but do you see that as a fair assessment of a fair standard that can be applied for specific nursing ratios? Is that something that if we were to follow a standard, that would be a good standard based on nationally what is said?
Senator Pat Kelly, I'm going to have some of the nurses going to come up, some chief nursing officers. They may be able to answer that question a little bit better. But, you know, you hit on a point that came up during the earlier testimony, and that is someone came up and said, you know what, we try to staff at adequate levels, but things happen. And the number one thing that happens, and wasn't discussed, was nurses call off. And when that happens, and it happens right before a shift, it is difficult. You know, these pools that they talk about aren't gigantic, and you don't know how many nurses are going to call off. And when you hear about 1 to 10 ratios, that's not what's been set up in the plan. That's what happens. It's either a result of people calling off or patient surges. You've heard the labor and delivery. We don't know when people are going to have babies and come in. I mean, you think about how many babies in this state are born to mothers who've not received prenatal care. They're not even on the radar screen. And so all of a sudden they come to the hospital and we have to deal with them. So if all of a sudden our nurses are, you know, at the maximum, you're going to have to send that mother to another hospital, or they're going to deliver in the emergency room, which is not a good alternative.
Great, thank you. And I think, you know, Senator Nguyen mentioned that she would be open to amendments that deal with call-outs and emergencies and so forth. And so I would hope that you can, after this presentation, that you can work with her on some of those concerns that I reiterated earlier. But I guess I just want to make sure that, you know, we do this in primary care. We always have standards that we look towards in terms of the best models. And so is it a fair assessment to say that the Joint Commission staffing standards are usually the ones that we look towards in terms of best practices? Is that, based on what I mentioned earlier, in terms of med-surg intermediate units and ICU, that's usually the standards that we look towards in terms of best practices?
I would think that, Pat Kelly, I think we follow Joint Commission as closely as we can, but things happen.
Got it. Thank you so much. I just wanted to make sure that we were clear, because I know that there was a lot of questions as to what the American Nursing Association said versus what boards of nursing have said versus what states have said. So I just wanted to make sure that the standards that we adhere to generally as hospitals is generally what the Joint Commission accreditation standards are.
And Senator Pat Kelly, as I said, I'm not super familiar with those. Other people will be coming up and they can answer those questions. But, you know, we're always trying to staff. The thing that bothers me about this whole discussion is it's not that we don't want to hire more nurses. I mean, we've got 780 openings for nurses. We will hire more nurses. The problem is that we're not getting them. And all of you know that I have been up here for years trying to expand nursing programs in this state. And we worked with the legislators to get $20 million 2 years ago to do that. We have a health system that has opened up their own nursing school. I mean, we're taking proactive measures to get there, but it's difficult and it's going to take time. And unfortunately, our population keeps expanding at the same time.
Great, thank you, Mr. Kelly. Senator Sung.
Yeah, thank you, Mr. Chair. Mr. Kelly, thank you for your presentation. You kind of codified what I started saying, is that we have a nursing shortage here in Nevada, and having nursing ratios is going to exacerbate that problem. But I want to pose the same question to you that I posed to them, and that is, what if hospitals cannot meet the staffing requirements? I talked about reducing the number of beds, closing units. I want you to elaborate on that and talk about, you mentioned the experiment in California with nursing ratios. If you can expand on some of the data you were talking about before.
Thank you, Senator Patrick Kelly. So California, when they implemented the nurse staffing ratios, they did see the number of beds reduced in the state that were available. They also had a variety of other experiences in terms of a lot of maternal type services were discontinued and other services as well. And, the other thing about California is everybody says, well, all these nurses are flocking. They're projecting a $30,000 to $40,000 nurse shortage in a very short period of time. So it has not solved their problems. The only other state that has implemented statewide nurse staffing ratios is Oregon, and they just did it about a year ago, and they just had a massive strike, nurses strike in the state. So when we talk about all the legislatures across the country who have looked at hospital-wide staffing, there's only 2 states that have done it in the last 20 years. Now, there are some states who have had specific units that they have done, but not hospital-wide nurse staffing ratios like we have here.
Vice Chair Taylor.
Thank you, Chair, and thank you, Mr. Kelly, for the presentation. Excuse me, I'm just going to ask a couple of the same questions asked from before. One is, my understanding, and please correct me if I'm wrong, is that hotel management is supposed to work with staff and put together a staffing plan. Do I have a correct understanding? I mean, hospitals, yes.
I understand.
Yeah, not hotels. Hospitals, sorry, hospitals. It's late, sorry. This is the wrong meeting. This is HHS, huh? All right, my bad. Okay. Yeah, please, Mr. Kelly, please
Pat
go ahead.
Kelly. Yes, under state law, there's a requirement to have staffing committees. And so the staffing committees do get together, they come up with a plan. And so that's what kind of one of the earlier presenters hinted to. There is a plan, but stuff happens, like call-offs and different things, that cause that plan to go out of whack. And so, that's an issue. And, if you wonder, do staffing committees work? I would suggest that this bill tells you that they do, because in that bill, they create 2 more staffing committees, one for technical staff and one for service staff. So why would you create 2 new committees if the first one doesn't work?
Follow up, Chair. Thank you. Yeah, that was so. To the best of your knowledge, and I know that you represent the association, not you don't work at the hospital or the hotel for that matter, unless you have a little side hustle. I don't know. So to the best of your knowledge, though, are those staffing committees working, and are they workable? I mean, are they? Because I have to tell you, this is some of the conversation that I've got, and that's part of what I've been doing is sharing some of those things. Is that the staffing committees aren't really happening, and that thing isn't working, and that's why the working conditions have been such an issue. I just want your opinion on that. That would be very helpful.
Pat Kelly, for the record, to the best of my knowledge, they are required by law to meet. They're required to file documents or to maintain documents related to the staffing committees. People who have an objection to the plan that's developed are allowed to file their objection to the staffing committee. So it's my understanding that, yes, they are active.
Thank you, Mr. Kelly. One more question, sir. Thank you, Chair. Just asking, I've heard, again, in conversations and preparing, there's something called assignments despite objections. Right? Okay, good. Oh, good. So how are your members, how are hospitals currently dealing with those?
Pat Kelly, it's my understanding that that nurse staffing committee can file such an objection when the plan is developed, and also during the course of any day that they can file those as well, and that they're reviewed by management.
So to your knowledge, thank you, Chair. So they're filing those, but are they being used to help protect nurses, or what's your opinion? What do you think?
Pat Kelly, I think that
because I got some feedback that it wasn't. Because I want to get the other side.
Yeah, well, no, I do think that's the whole point. They're reviewed. It doesn't mean you can act on every single one, because if there were 20 call-offs that day, that contributed to the problem. So people might not feel like it was resolved to their satisfaction. But yes, I think that people take them seriously.
Okay. I appreciate that, Mr. Kelly. Thank you so much.
Thank you.
Any other questions? I just have one more before we go on. So I mentioned earlier that it's kind of more on the oversight, right? If there was an amendment that was proposed to say, rather than prescribing in law what the ratio is per unit, perhaps being more flexible with the staffing committees and giving them more authority to make those determinations, is there an opposition then to say if the staffing commission, if the staffing review committee, et cetera, notices that there's a gridlock, right? The staffing committee at that hospital is saying, you know, clearly the hospital does not care and we are noticing an increase in staff turnover in this particular unit, or the increase of HAIs based on the quality metrics. Therefore, we now have to report it to, for example, the labor commissioner. Is there any hesitation or opposition to making sure that the staffing commission or review committee is in compliance? Is there any pushback towards that? If we were to remove the nursing ratios themselves but put them on the committee, I guess what I'm trying to enunciate is, if there is a fault and we have to refer it back to the labor commissioner to investigate, would you be opposed to that?
Senator, I don't know, Pat Kelly, I don't know enough about this to give you a definitive answer, but certainly something we were willing to talk about.
Great, thank you so much. Let's go ahead and open it up to testimony in opposition. So if you are here in opposition, I ask for folks to please come forward in Carson City and in Las Vegas, and then obviously we'll do the same round. So we'll do 3 here, 3 down there, and then we'll do 3 online. You may begin.
Members of the committee, for the record, my name is Melody Osborne, and I'm the Chief Nurse Executive at Renown Health. SB 182 presents several challenges that could inadvertently impact patient access, the quality of care, and exacerbate our current nursing shortages. When hospitals cannot meet mandated staffing levels, they will be forced to reduce available services and close hospital beds, leading to increased patient wait times and potentially forcing patients to seek care in other states. The nursing shortage in Nevada is a complex issue that requires a comprehensive and a strategic approach. While SB 182 aims to alleviate the shortage through mandatory staffing ratios, it fails to address the fundamental issue, and that is an inadequate pipeline of nurses to meet our demand. I want to take a moment to just share with you a personal experience I've had with mandated ratios. My mother-in-law resides in the Bay Area. One day she began to experience chest pain and called 911. An ambulance arrived and assessed her. Her EKG did not appear to show a heart attack, but her chest pain was persistent, and they determined she needed to go to the hospital to be evaluated. Once in the ambulance, they attempted to take her to the nearest hospital, but that hospital was on divert. They had met their ratio. She went to the second hospital and was then diverted to a third hospital because they were at ratio. Once she arrived at the third hospital, they determined that she had a blockage in one of her main arteries and she needed to go for a cardiac catheterization and stent. After that procedure, she suffered a major complication and had to have emergent vascular surgery. After that procedure, she needed to go to the ICU, but the ICU was at their ratio. So for the remainder of her stay, she went back down to the emergency department for several days until she was ready to be discharged. As a registered nurse for over 23 years, I can assure you that that was not quality of care. I want you to imagine for a moment your loved one needs immediate medical attention, but the local hospitals are already at their mandated ratio.
Complete your remarks.
Where will they go? Nevada needs more nurses, not mandatory ratios. I urge you to vote no on SB 182.
Members of the committee, my name is John Hardwick. I'm an emergency physician in Reno, Nevada, and the current president of the Nevada chapter of American College of Emergency Physicians. Look, I want to be for this bill, right? Because I want our patients to be safer and I want our nurses to have better livelihoods and better working conditions. But I think it is highly problematic and actually will work antithetically to what it aims to do. Probably the most dangerous place to be in a hospital if you're sick is the ER waiting room. Right? And I think this bill will actually exacerbate ER wait times significantly. If beds need to be closed upstairs or in the ER because they can't fill these nursing ratios, what happens is patients start filling up in the waiting rooms. We have EMTALA. That means that we can't close the hospital. People who show up to the ER, we have to see, okay? So that means when they're in the waiting room, they just sit in the waiting room. If they can't be admitted and they're in the ER, they sit in the ER and can't be placed above, like your mom had to come back down to the emergency department, right? What happens then is the nurses who are taking care of those people, right? We try to use the float pool, try to increase their ability to treat all those patients, but ultimately that float pool gets exhausted. As that float pool gets exhausted, now the nursing ratios exacerbate significantly in the emergency department. That is very, very unsafe for patients, and it's a very, very bad working environment for our nurses. Furthermore, what I think that this bill may do, to Dr. Titus's point, was that let's say the urban hospitals are able to fill these nursing ratios because they have higher ability to pay these nurses. What's going to happen is our rural hospitals are going to get affected. Our rural wait times are going to get worse, and our rural outcomes are going to get worse. So we're basically taking our sickest patients, the patients in the emergency department who are often indigent, the people who don't have health care, our rural patients, and we're putting them at higher risk, and we're also making nurses' lives there much more difficult. Thank you.
Good evening. My name is Adam Hines, ADAMHEINZ. I'm the Chief Operating Officer for Remsa Health. And I'm here today to speak on behalf of our organization regarding the proposed bill, Senate Bill 182. While we understand the intent behind the bill, we must express our concerns about the potential unintended effects that it will have on out-of-hospital emergency medical service. As written, this bill could unintentionally exacerbate EMS offload delays, something in which a lot of the times was referred to as what's going on in California, which is significantly impacting their EMS system as far as their ambulance off times. This obviously takes EMS out of the system and is forced to wait longer at hospitals struggling or unable to meet the mandated nursing ratios. That not only ties up valuable EMS resources, but also delays emergency response times for the critical incidents in our community. Furthermore, as we saw during COVID when medical staff was limited, hospitals may be forced to go on divert more frequently if they cannot maintain the required nursing ratios. This could result in patients being transported to facilities that are farther away, increasing the time EMS is providing care and reducing availability for that next emergency call in any of our communities, which potentially could compromise the timeliness in which we are ready to respond. In addition, if patients are aligned with a particular payer and their preferred healthcare facility is not accepting patients because they're on divert, it not only can cost insurance companies, health systems, but most importantly, our patients additional money as they no longer are receiving care in network. In addition, this could also lead to unnecessary repatriations for the ambulance service for certain patients when that system opens, which is expensive and again consumes vital resources. Finally, as Senator Titus had said, this bill may inadvertently place additional stress and unnecessary competition for nursing resources as institutions vie for the limited nursing talent we have in this great state. With many Nevadans struggling to access health care, we cannot make it more difficult. It is crucial to recognize that many of our Nevadan resources are finite. So in conclusion, while we support the goal of improving patient care and safety and nursing retention, we urge the committee to consider the potential negative impacts of this bill, specifically on EMS.
Thank you so much. Let's go to Las Vegas. Please begin.
Chair Donati and committee, my name is Dr. Diane McGinnis. I am a nurse practitioner who worked 10 years in hospitals. I've been a nurse for 27 years. I am the vice president of the Nevada Nurses Association and the chair of their legislative committee. I'm sitting here today with many nurses at my back who may not understand our association's concerns with this bill. It is the opinion of the Nevada Nurses Association that we cannot support this bill as written. We greatly appreciate the intent of the bill and understand it's about better working conditions for nurses in the hospital setting, which we endorse with all our heart. It is our opinion this bill as written is attempting to put administrative code into statute. It is way too detailed and precise. To put it simply, the bill should say, follow the golden rule, and then have these details in the Nevada Administrative Code. If the numbers are off, as you know, 2 years can be a very long time to wait before they can be changed. If they're in the NAC, they can be reworked and adjusted between sessions. This bill, as written, requires hospitals to be able to, oops, I lost my place, to predict the future. As in the spirit of humor, as Dr. Titus said, we're in Nevada. If we could predict the future, we would all be at the machines pulling the lucky handle. Let there be no doubt, working conditions for nurses are affecting their well-being, their mental health, and their burnout. Nurses are less tolerant of poor working conditions and are walking after just a few years of practice. Let's work together to improve nursing satisfaction with their careers, not their jobs, their careers, which should improve patient satisfaction, lower mortality, support shorter patient stays with less patients returning to the hospital within 30 days of discharge. We propose the language in the statute be simplified and details be intended moved to the NAC so we can make changes between legislative sessions if the original plan isn't working. Thank you for your consideration.
Good afternoon, everyone. My name is Pat Walker, and I am the Chief Nursing Officer at Valley Health System. And I'm a concerned citizen with firsthand experience in the challenges and complexities of hospital staffing. While I fully support improving patient care and ensuring nurses have safe working conditions, I strongly oppose the implementation of state-mandated nurse-to-patient ratio in Nevada. Mandated ratio may seem straightforward, but they fail to address our health system real issues, such as flexibility in patient needs, workforce shortages, and access to care. Healthcare facilities would be hit very hard, potentially leading to closure or service reduction, placing patients at even greater risk. I will focus mostly on the emergency department since that's the gateway to our hospital. The ED operates under unpredictable condition with patient volume and acuity fluctuating hourly. The ED must constantly adapt to surges in patients' arrival, including traumas, cardiac arrest, mass casualty incident. A fixed patient ratio does not allow for real-time adjustment, potentially leading to critical patient care delays. They may be forced, as a speaker before me had said, may be forced to turn away ambulances or place patients in waiting rooms for extended periods. Flexing resources and prioritizing care over rigid ratio can be life-saving in a crisis. Mandating ratios does not create more nurses. It only increases staffing pressure on hospitals already struggling to fill positions. Due to an inability to meet the requirements, hospital may have to close ED beds or limit services. This could push already overworked nurses to leave the profession, exacerbating the shortages rather than solving it. In conclusion, while well-intended mandated nurse-patient ratio in the ED could create unintended consequences that ultimately harm patient care. The speaker before spoke of her mother.
Thank you, ma'am, for your comment. Unfortunately, we've run out of time. We can move on to the next one, please.
Thank you. I implore you to reject mandated patient ratio. Thank you.
We'll do one more in Las Vegas, and then we'll go to AVH online.
Yes, good evening. Thank you, Chair Donyate, Vice Chair, and committee members. My name is Jeannie Reeves, and I'm the Chief Nursing Officer at Summerlin Hospital, a 496-bed hospital that is located in Las Vegas. I have over 40 years of healthcare experience as a registered nurse, and I am speaking in opposition of this bill. I could go on and ditto my colleagues who have spoken before me, so I will therefore stress the strain that a mandated ratio will take on areas such as specialized units, such as pediatrics or oncology. You could go on to say trauma, ICU, OB, etc., as we do many specialties within an acute care hospital. To place ratios would be an incredible burden. The flexibility that is required in managing such services are crucial. Acuity nor volume can change in an instant. Patient ratios do not allow the flexibility that is required when it occurs. The adage of a nurse is a nurse is a nurse is a fallacy, and float pools and travelers are an extinct model as we move forward. I cannot ask an adult med-surg nurse or ICU nurse to assist in floating to a pediatric unit or oncology. Why? Simply said, pediatrics is not just caring for smaller units. Oncology is an extremely complex as well, given the current therapies that exist. Summerlin provides the only pediatric oncology services in Las Vegas. To place ratios into effect could put those services in danger of either being limited up to and enclosing beds or closing the service in totality at all. That would require our pediatric patients to proceed outside of the state of Nevada for oncology services. I would like to address what has been mentioned with the current staffing committee structures. I guess
Ma'am,
I
if
am
you can
very
please
fortunate to
complete
be
your
at
comments.
Summerlin. I'm sorry?
You've run out of time. If you can please finish your
Oh,
comments.
sorry. If I could just say staffing committee structures do work. We have a very active committee at Summerlin, and we do not support mandated ratios. Thank you so much, and I implore you to not pass this bill.
Thank you so much. AVH, let's go online, please.
If you would like to testify in opposition to Senate Bill 182, please press star 9 now to take your place in the queue.
Hi, I'm Peter Guzman, president of the Latin Chamber of Commerce, and I want to respect everybody's time, so I'll be short. In its current form, the Latin Chamber cannot support this because it is too risky, and we believe that it could have the exact opposite effect of what is intended, and that is a risk too far. So we ask you to not support this bill at this time. Thank you.
Following the last
Hi, this is Tej Vanita. I'm CEO with Encompass Health. I'd like to echo what my colleagues have said. Myself and my team believe these mandated ratios are going to exacerbate the current nursing shortage in Nevada and ultimately potentially reduce crucial access to care for Nevadans. It's something I take very seriously, and although I understand the intent from our nurse colleagues, I agree the risk is too great. The significant nursing deficit that we've spoken about would make it incredibly difficult for us to hire enough nurses to meet the ratio requirements. And ultimately, not enough nurses means that we will be unable to meet the ratios and deny or limit access on a very significant scale. For those reasons, I stand with my colleagues and urge you to please vote no on Senate Bill 182.
Good afternoon, honorable members of the Nevada Legislature. My name is Jennifer Crossley. I'm a registered nurse and the director of the Renown Transfer and Operations Center. I wish to express my strong opposition to mandated nurse staffing ratios. From 2022 through 2024, Renown received over 2,700 transfers from California hospitals. If Nevada implements similar mandated staffing ratios, our hospital capacity will be significantly reduced. This would limit our ability to accept Nevada residents in need of higher levels of care, particularly those transferred from rural facilities within our state. While staffing and patient care are critical concerns, rigid staffing ratios will strain our healthcare system and ultimately harm the very patients we aim to protect. I urge you to vote no on mandated nurse staffing ratios. Thank you for your time and consideration.
Thank you so much. Let's come back to Carson City. Please begin.
Hi, good evening. Michelle Joy, President and CEO of Carson Tahoe Health here in Carson City. SB 182 targets communities over 100,000 residents, but its impact will extend beyond those two counties. The bill will directly impact Carson Tahoe Health and the residents of our primary service area, which is Carson City, Douglas, Story, and Lyon County, our rural areas here. At Carson Tahoe, we compete with Reno hospitals for staff. If they're forced to implement nurse staffing ratios, we'll have to do the same. No nurse is going to work at Carson Tahoe if they can take care of fewer patients at a hospital in Reno. This bill just doesn't impact Clark and Washoe counties. It's going to impact, as you've heard, everybody across the state. Today, Carson Tahoe staffs 159 acute inpatient beds and 42 behavioral health beds. We operate at over a 95% capacity. To meet our community's needs, we actually need more beds, not less. When we look at this bill, in order to meet the staffing ratios based on our current number of beds, we would need an additional 50 nurses. There are not an additional 50 nurses here in Carson City. Our only viable option will be to reduce services. That means eliminating our behavioral health programs and reducing an additional 20 inpatient beds. As a result, over 1,700 patients from the Quad counties would be forced to travel further for care, facing delays that in some situations could be life-threatening. Nevada already struggles with a healthcare access problem. This bill would make it worse. As we've seen in California, mandatory staffing ratios don't solve workforce shortages. They force hospitals to reduce beds and cut services. We simply can't afford that outcome in Nevada. Thank you for your time.
Hello, I'm Don Butterfield. I'm the CEO at Reno Behavioral Healthcare Hospital. We're a psychiatric hospital with 124 licensed beds. And we treat adults, but we also treat kids. And I'm proud to say we're the only hospital in all of Northern Nevada that provides psychiatric inpatient treatment for kids. We have 124 beds, but the reality is that only 90 to 100 are operational. And the reason for that isn't community need, because we know there's a severe mental health crisis in Nevada. The reality is there simply aren't enough psychiatric nurses in Reno. And so 24 to 34 of our beds go unused every day, and we know there's community members in need. So even the employees that we do have, the nurses that we do have, 20% are agency nurses. And they're travelers oftentimes who don't reside in the community, and we know that they don't have the same level of, oftentimes, same level of commitment and engagement to our patients, our community, as our employed nurses do. And we're very grateful for the employed nurses that we do have. If this bill were to pass, we would have to shut down half of our beds, and we would have to, many of our programs and services would be in jeopardy, including our youth programs. If our youth programs were reduced or shut down, even if they were reduced, many kids would not have access, or they would have to seek care outside the community, perhaps even outside the state. Because like I said, we're the only inpatient provider for psychiatric treatment for youth. Many of our other programs would be in jeopardy, like our substance use disorder program. And with that, we know that Nevadans already have challenges accessing mental health services. This bill would make it worse, and I encourage you to oppose it. Thank you.
Good afternoon, Chair and members of the committee. Allison Herzik, Director of Nevada Government Relations for Dignity Health St. Rose Dominican. On behalf of Dignity Health St. Rose and our 7 acute care facilities in Las Vegas, we are here today in opposition to Senate Bill 182. As the only nonprofit health system in the Las Vegas Valley, we are committed to high quality and compassionate care, but believe a one-size-fits-all approach to staffing will negatively impact healthcare delivery. I'd like to take a moment to thank Senator Wynn for her kind words regarding our mission-driven system. We value our partnership and collaboration with our frontline healthcare workers and their union representatives and have established staffing ratios through the collective bargaining process that reflect our commitment to our mission, staff, and patients. Mandated ratios fail to account for the complexities of care, especially amid Nevada's severe nursing shortage. Such mandates could force hospitals to limit admissions, reduce services, and compromise patient access. Financially, compliance with this bill as written would cost St. Rose over $28 million annually, threatening vital programs and services that benefit the most vulnerable of Nevadans. Staffing decisions should be based on real-time patient needs and collaboration with our frontline healthcare workers, not rigid mandates. We urge lawmakers to focus on workforce development, recruitment, and retention to strengthen healthcare in Nevada, and we respectfully ask the committee to oppose this bill. Thank you for your time.
Good afternoon, Kiana Cole, Keyona, last name Cole. I am the Regional Chief Nursing Officer at Intermountain Health, and we would respectfully request your opposition to Senate Bill number 182. Intermountain Health in October announced our plans to build Nevada's first comprehensive standalone children's hospital in Las Vegas, and we currently offer care in more than 80 clinics at over 65 locations throughout the valley. Our fundamentals drive a focus on quality and safety while supporting our caregivers' well-being and providing an excellent experience and outcomes for our patients. SB 182 could result in unintended impact to patient care by limiting flexibility of the healthcare team. While the primary purpose of the mandated ratios was to prevent nurse burnout and enhance quality of patient care, studies to date in California and Massachusetts show mixed results, suggesting there is more work to understand the complexity of our healthcare system. California's legislation does not provide consistent nor conclusive evidence that patient outcome predictions around improving quality and safety were realized. The impact on patient outcomes like mortality, which is the number of deaths due to a disease divided by the total population, readmissions, and length of stay vary depending on how mandated ratios are implemented. With mandates, hospitals may struggle to adjust staffing based on patient needs, impacting the quality of care provided. Mandation increases in labor requirements can have unintended consequences for hospital operations, causing cuts to important areas, as has been said before. In an ever-changing healthcare landscape where people are living longer and we are facing an ongoing nursing shortage, as has been said before, mandated staffing ratios can reduce the flexibility of the care team responsible for patients. During a patient's course, what they need varies, can be heavier on the front end and less on the back end. Please help ensure
Ma'am, if you can
hospitals
please complete your comments.
are able to provide the highest quality of care and best possible outcomes for patients in Nevada. Oppose Senate Bill 182. Thank you.
Thank you. We'll take two more in Vegas, and that will conclude our opposition testimony.
All right. Thank you. For the record, my name's
Sorry,
Steve.
sir. We're in Las Vegas.
Oh, I'm sorry.
Two more in Vegas, please.
Good afternoon, Chair Donati and members of the committee. My name's Annette Greenwood, and I have the privilege of serving as the Chief Nursing Executive for HCA Healthcare's Far West Division, which includes Sunrise Hospital, Sunrise Children's Hospital, Mountain View Hospital, and Southern Hills Hospital. We proudly serve our hospitals proudly serve our customers in Nevada, serving just under 1 million patient visits each year. And this includes our most vulnerable pediatric and Medicaid populations. Today, I must oppose SB 182 and echo the comments made by the Nevada Hospital Association regarding patient care, quality, and the severe nursing shortage. I do not support mandatory nurse staffing ratios due to my personal experience as a nurse in California during and since the implementation of nurse staffing ratios in 2004. When ratios were implemented, I observed an increase in emergency department wait times due to limited bed availability as a direct result of limiting nurse-to-patient ratios. The ratios increased the cost of care significantly and, in my experience, did not increase the quality of care. The nursing shortage was exacerbated by the mandated ratios, and the required enforcement bureaucracy drew precious resources away from an already overburdened public health system. Again, none of which resulted in better care. While I absolutely believe in appropriate coverage of patients by RNs based on acuity to ensure quality care is delivered, this requirement is already enforced within the CMS, Joint Commission, and state required standards of care. Mandatory nurse staffing ratios are not the solution to the challenges we are currently facing in our hospitals. I urge this committee to consider the broader impact this legislation would have on our patients and healthcare system. I respectfully ask that you oppose SB 182. Thank you for your time and consideration.
Thank you, Chair and members of the committee. My name is Emily Osterberg, and I'm here representing the Henderson Chamber of Commerce and our over 2,000 members to express our opposition to SB 182. While we understand the intent of the bill, we are concerned with the one-size-fits-all mandate for staffing. Nevada has many amazing hospitals and healthcare workers. However, we are also currently having a nursing shortage, and this bill would make that even more difficult to staff hospitals. Combined with the high additional costs, we fear this legislation will have a negative effect on the already fragile healthcare system. For our members, their employees, and their employees' families, we are opposed to SB 182. Thank you.
We'll take one more. You got 1 minute. Well, Carson City, please.
So for the record, my name is Steve Rohn. I'm the Chief Nursing Officer at Renown Regional. As we've talked about, Nevada continues to face an ongoing challenge with filling all open nursing positions. We pride ourselves with the gains we've made over the last few years, but the proposed bill would exacerbate this situation. This drastic increase in staffing needs would strain our capacity to provide quality care. Forcing a one-size-fits-all approach, as California did, takes away a nursing team's autonomy in evaluating the level of nursing care required for our patients. Nurses are trained to evaluate a patient's needs, and this proposed bill would take that away. We would not be able to react to our capacity surges like during a respiratory virus season and adjust our staffing needs to meet the demands of patient care. Our units at Regional often experience additional shortfalls due to call-offs. On average, across Renown, we manage about 400 to 500 call-offs per week. I'm proud to say we do have a robust nursing float pool that helps supplement this, but not always to 100% of the need. This bill at Regional would create approximately 400 new nursing positions and 108 new certified nursing assistant positions. The financial implications of the mandated ratios would be devastating for healthcare organizations. To cope with the increased staffing requirements, we would need to close up to 70 beds. This reduction would restrict access across our community, the VA hospital, and our rural partners who rely on us to care for their patients when they need a higher level of care. Our ED wait times would increase. Our first responders would be waiting for open bays to become available, whereby they would be unable to respond to that next 911 call. Mandated ratios would have severe negative consequences for healthcare facilities. The increase in vacancies, coupled with the financial strain and reduction in available beds, would ultimately lead to diminished care for our community. I urge you to vote no for SB 182. Thank you.
Thank you so much. That concludes the opposition testimony. So for folks that did not get the chance to participate, if you can, the same way that we did for support testimony, if you can send in your comments to us, we would greatly appreciate it, and we can upload it as an exhibit. So now we have concluded the opposition and support testimony, so we'll move on to the last portion of the bill hearing, which is anyone testifying in neutral on this bill. So if you would like to testify in neutral, we ask for you to please come forward. Seeing none here in Carson City or in Las Vegas, AVH, is there anyone that would like to testify in neutral on the bill?
Chair, the public line is open and working. However, there are no callers wishing to testify in neutral at this time.
Thank you so much. Senator, do you have any closing remarks? Go ahead.
I just wanted to, Rochelle Wynn for the record, I just wanted to thank those people in Las Vegas that have stayed this entire time. And I also wanted to let this committee know there was no disrespect to the people that are here. We had a lot of people, nurses, that needed to get back to work tomorrow. And I'm sure that our hospitals and their employers will appreciate the fact that they needed to get back on a plane to go back to Las Vegas. And they didn't mean any disrespect. They just wanted to make sure everyone was aware of that. I'm just going to reiterate that there are hospitals in this state that do it right. There are hospitals in this state that are trying to do it right. where they put patient safety and nurse retention are at our highest standards. Every hospital in this state needs to have those same standards and objectives if they want to keep their patients safe and they want to keep those 12,000 new nurses that I talked about that we've added just since 2020. The administrative and executive should not dictate care in our state. The current shortfalls of these hospitals are falling on their patients and their staff. And Senate Bill 182 is and always has been about patient safety and nursing retention. It's time to tell our nurses that they matter. It's time to tell our patients that they deserve more than 6 minutes. I'd urge your support of Senate Bill 182.
Thank you so much, Senator. And again, thank you for all the folks that participated in this process. We wanted to make sure that it was fair and transparent for anyone that wanted to participate. And just wanted to reiterate thank you to our nurses that came out, of course, throughout this bill presentation. So with that, we're going to go ahead and close the agenda item, and we will now move to the last agenda item, which is public comment. So anyone that would like to provide public comment, they are free to come forward at this time. Again, it's 2-minute remarks, same limit as before. The only thing is, we cannot talk since the bill hearing has been closed. We can't use public comment to talk about the bill. So it can be any other subject besides that. So anyone in Carson City or in Las Vegas. We've had a technical glitch. It sounds like we did have folks that wanted to testify in neutral virtually, so I'm going to reopen the hearing for the Senate Bill 182 and ask AVH if there's anyone that would like to testify in neutral on the bill, if they can go ahead and do so.
Apologies about that, Chair. Thank you so much. If you'd like to testify in neutral on SB 182, please press *9 on your phone to take your place in the queue. Once again, if you'd like to testify in neutral on SB 182, please press *9 on your phone to take your place in the queue. Chair, there are no callers in neutral at this time.
Thank you so much. Now I'll go ahead and close it again. So if there's anyone for public comment, we didn't have anyone here in Carson City or Las Vegas. AVH, is there anyone that would like to provide public comment at this time?
If you'd like to participate in public comment, please press *9 on your phone to take your place in the queue.
Hi, my name is Dr. Ray Nagy. I'm a neurosurgeon in Las Vegas, Nevada. I'm the former president of the Board of Medical Examiners, former chair of the Department of Neurosurgery at UMC, lifelong Nevadan. I wanted to comment on a lot of the things I heard today, and that the commentary regarding the nursing shortage failed to address the fact that during COVID-19, we were able to bring nurses to Nevada by increasing the amount they were paid. So the nurses during that period of time were being paid $200,000 to $300,000 a year, and by increasing the payments to nurses, we were able to staff the hospitals appropriately. While it's clear that that will create financial stress for the hospitals if we have to create a bidding war for nurses across the nation to try to bring them here, we'll be able to affect that kind of increase. We can increase that nursing if we increase the funding to hospitals. I spoke to several of the CFOs at many of the hospitals, and they believe that they can get $20 million on average increase in revenue if the bills in commerce and labor that decrease the ability of insurance companies to down code their bills and delay payments if those bills can be passed, so preventing the insurance companies from stripping that much wealth from Nevada. So $20 million at each hospital will be a substantial amount to spend towards improving nursing in those hospitals. Thank you.
Chair, the public line is open and working. However, there are no more callers at this time.
Thank you so much. I'll go ahead and close public comment. Members, are there any questions or comments before we adjourn? Seeing none, that concludes our meeting for today, and our next meeting will be on Tuesday, March 11th at 3:30 p.m. Meeting's now adjourned.